My substance use started around 12 years old. I grew up in a single mother household. We didn't have much money, so I fit in only with people that were similar to me, that didn't have much money, that had traumatic situations going on in life. I didn't feel a part of life at that time. I used substances to feel a part of life. Throughout time, I had a lot of consequences come from my substance use. One of them being incarceration. I spent 4 years incarcerated in federal prison for distribution of cocaine base, crack cocaine. While there wasn't a whole lot of rehabilitation going on. And that can be shown in evidence by the fact that I got out and went back to using. I continued to use despite multiple consequences in my life, losing families, friends, children, myself. It came to a point where ultimately I had no desire to continue to live the way that I did, and I didn't know how I could stop. I didn't see resources available to me. After multiple trips to India Street in Portland, Milestone, and detox, I started to formulate an idea that there was a community of people, right? I got an idea of 12 steps and that that recovery was possible. I'd like to say that was enough to get me to stop, but it wasn't. I left there and thought I had a solution. I just had to get rid of the drugs. And as soon as I stopped using substances, then I would naturally get better. I couldn't grasp that I had a mental disorder that was different than other people. Ultimately, addiction cost me my life more than once. I overdosed twice in the span of 2 weeks. And after the second overdose, I was content just to die. So it was suicide, or it was giving 100% to recovery, whatever that might look like. I made a decision that day to try to live. And if it didn't work, well, I always knew how to die. So starting from that day, I decided to become involved in the recovery community. Thankfully for places like Portland, Maine. Portland was a godsend. The Portland Recovery Community Center, the 12-step groups, and all of the recovery allies. I was able to find my tribe, my people, and realize that I'm not alone, not only in my downfalls and my flaws, but in my ambitions, my hopes, and my dreams, to not have those downfalls and flaws take my life. I lost a lot of friends on this journey, and I sacrificed a lot to stay high. As of today, I'm 19 months in recovery. I am an organizer with Maine Recovery Advocacy Project. I am a member of a 12-step fellowship, and I am a part of life. Today, I get to be a father to 3 children. I get to be present for my friends, family, and community. And I get to show others that are like me that there is hope and that we do recover.
Good morning. I'm Randall Liberty. I'm the Commissioner of the Maine Department of Corrections. Welcome to Advancing Medical Assisted Treatment Services and Corrections. Joining me today, Dr. Ryan Thornell, the Deputy Commissioner of Corrections, and Melissa Caminiti from WellPath. She's the Director of Medication Assisted Treatment, and she's working with our integrated healthcare providers. At the very beginning of Governor Mills' administration, she made it very clear that the priorities that were established for substance use disorder, and specifically opiate use disorder, were at the very top of our priorities. On January 2nd, she issued her first executive order, which expanded MaineCare, which was foundational to assist those individuals to get treatment for substance use disorder. On February 6th, Governor Mills issued her second executive order, which was to implement immediate responses to Maine's opioid epidemic. This created an environment where we're able to significantly enhance the treatment to individuals that suffer from this disorder. It established the director of opioid response, Gordon Smith. It established prevention and recovery cabinet, which I'm a member. It also made naloxone more available and established medication-assisted treatment in corrections, not only state facilities, but it also encouraged us to work with the county jails to do that. It also enabled many actions that significantly enhanced Maine's response to opioid use disorder. Ryan?
Greetings, everyone. During this presentation, we intend to accomplish the following objectives. We hope that you will better understand the need for MAT services in the corrections population and the process for implementing normalized medication-assisted treatment services in prisons and jails. We hope to challenge the stigma that's often associated with addiction and recovery, specifically impacting corrections clients. And finally, we hope you can better identify best practices in both program implementation and program delivery. So to begin, Commissioner Liberty will provide you with background information about the Maine Department of Corrections response to the opioid epidemic as our next set of slides. Commissioner?
The Maine Department of Corrections population significantly reflects what's happening with opioid disorder in the population in the state of Maine and nationally. It's our job as the providers of corrections in the state of Maine, working with the sheriffs and the county level, to identify what exactly people have for needs, we assessed what brought them to criminal justice in the first place, and to bring to bear what what programmatic needs need to be provided. 76% of our population have been identified as needing substance use disorder treatment, and 39% of those individuals needing opiate use disorder treatment. It's important to note, I think, as you look at this slide, that of the overdose deaths that occurred in 2020, we had 237, unfortunately. 47% of those individuals were previously involved with the Maine Department of Corrections. So this provides us a great opportunity, once individuals are in our care, to provide them the resources that they need, the programmatic resources and treatment that will assure them or give them the best opportunity to re-enter their communities in a safe within the treatment model. The treatment that we provided prior to MAT services were really committed to treatment services that were residential, outpatient, individual treatment groups that were offered at all of our Maine Department of Corrections facilities. We had an informal partnership with for continuity of care for individuals providing treatment in the community, and we provided individuals that information, those contacts, so they had a smooth transition back into the community. The response since, as I mentioned, the executive order number 2 that was issued by Governor Mills, that was issued in 2019, established the opioid response, statewide response, as I mentioned, establishing the director of opioid response, and specifically indicated that we need to have MAT, as is the gold standard, in corrections, both at the state level and to encourage the jails to do the same, in a sort of a continuity of care from the initial arrest to individuals being transferred back into the community smoothly. We established an MAT steering committee to do the work because not much of that work had been done historically, and that was spearheaded by Dr. Ryan Thornell. I'm pleased to announce that in 2021, we have a broad, residents in our care have broad access to MAT services. And we currently have 400 individuals, adult residents, that are actively involved in MAT services in the 5 adult facilities that we manage. And since the beginning of the MAT implementation, we've had more than 675 adult residents that have been participating in MAT services and successfully transitioned back into the community, and that has gone well thus far. In August of 2021, there'll be universal access for individuals in our custody, and we're looking forward to the universal access for residents. Dr. Thornell?
Thank you, Commissioner. So as we prepared to launch our first of its kind MAT treatment pilot in 2019, it was key for us to assemble the needed stakeholders really at the onset of the work and work through a methodical implementation process. And in order to do that, the first thing that we did in February of 2019 is we established a MDOC MAT steering committee, as the commissioner referenced. And the key to this steering committee's work was the multidisciplinary nature of the committee. We brought together security staff from our security operations division. We brought together our medical providers and medical staff, behavioral health staff, probation staff from the community, along with community treatment providers and reentry partners that are doing work in our Maine communities in order to tackle this project. And another key component that we added to the steering committee is we brought together staff from all ranks within those different stakeholder groups. And so it was important for us to hear perspectives and input from corrections staff inside of our facilities, along with medical staff and those individuals who are doing the work day to day and seeing the impacts and needs and to inform this process. The steering committee took 2 trips to Rhode Island. We established an informal partnership with the Department of Corrections down there and their leadership team that allowed us to come down and hear their lessons learned as their correction system had been several years into their MAT services. And these site visits really focused on 2 key topics. One was administrative oversight and development. And then the second visit focused really on the operations of MAT in housing units, in corrections facilities, which provided an opportunity for our facility staff to really put eyes on the process and develop recommendations for the steering committee to implement here in Maine. We also partnered with the Vermont Department of Corrections to learn lessons from them in their rollout. And for those familiar with corrections MAT, Vermont and Rhode Island really are the 2 front runners in this area prior to 2019 when Maine we tackled our services. The difference that we had to work through in this is Rhode Island and Vermont are coordinated correction systems in which they have jail and DOC individuals under one care within the same facilities. And so we had to really use our steering committee approach to establish what this means for state sentenced individuals in state facilities. In order to begin the implementation process, we found it very beneficial to reach out to all of our staff across our facilities and in the community to conduct a survey and then subsequent focus groups on their perspectives and views on medication-assisted treatment and what areas we needed to provide education and information to them prior to implementation. Because this really is a significant philosophical shift for many who have worked in corrections, the idea of medication that has largely been viewed as contraband and an illicit drug inside of correctional facilities now becoming a standard medication for use in treatment. We wanted to appreciate and recognize that background and that need for education information for staff. And so those surveys provided us with that and allowed us to have a very tailored approach to helping staff with this process and really get on board and championing the effort. And our goal was to launch in a very condensed timeline, which was 5 months. Our goal was to launch by July 1st of 2019, and that's what we did. So we designed the pilot program, which briefly was 3 facilities, which incorporated both males and females in secure facilities and pre-release statuses. We focused on those individuals who were 90 days to release into our communities in order to make sure the treatment services were targeting those prior to release for assistance before we expanded the program from there. And so because of that, our focus really was on continuity of care, rapid access to treatment upon release, along with harm reduction and support and communication with our probation partners within the department. Given the pilot was initially focused on those 90 days to release, continuity of care was critical. to ensure the transition from incarceration to community treatment was seamless. We all know that releasing from incarceration is a very complex process already, and then ensuring that treatment services in place are seamless just adds another dynamic to that. Luckily, as Commissioner Liberty noted in his remarks, Maine Care expansion was well underway as we began implementing our MAT services, and we forged a very strong partnership with the Office of Maine Care Services in order to ensure that individuals releasing from corrections, not just those on MAT services, who qualified for Maine Care and Medicaid coverage, had those benefits in place and active the day of release. This strengthened the continuity of care and access to treatment services as part of that reintegration process. Additionally, we ensured that we had continuity of care partners and treatment providers across the state of Maine who had access to all communities and all services to ensure that there was rapid access to treatment upon release, with our goal being that individuals releasing with continuity of care plans in place had access within 72 hours of release to a referral partner and treatment agency. And finally, we ensured that harm reduction efforts were in place as part of the release process, including treatment on the use of naloxone as a harm reduction effort, as well as a naloxone kit being provided to individuals releasing to the community with alongside a smart cell phone to support telehealth and communication services as part of the release. And we did all of this because our intended outcome was sustainable transition to the community and community treatment. And we wanted to have the highest rates of treatment retention possible at the onset of our services. And so as you can imagine, as this started, we recognized the importance and the impact and the need of our services immediately from July 1st onward. And so we quickly developed an urgency to expand services. And so in November of 2019, we initiated our first expansion, which added another secure facility and another pre-release facility for males to have access to MAT services. And we put forth another round of staff education and information to ensure staff were continuing to support the services and that their questions and concerns were being addressed adequately. And then in February of 2020, we added our final facility, which was another secure male facility. And that brought MAT services to all of the department's facilities. We also expanded our time frame at that point from 90 days to release to 180 days to release. And so that was the catchment of males and females who became eligible to be inducted onto MAT services when they were deemed medically appropriate by our medical providers and medical team. During that entire process, we also worked closely with the Department of Health and Human Services, Office of Behavioral Health, and the Maine Sheriff's Association to support the county jails in their efforts to implement medication-assisted treatment. One strategy of which was a model policy that was developed by that team for county jail use as they rolled out their services. During all of these expansions, our focus remained really on the quality of treatment services and ensuring that medication-assisted treatment remained a medical treatment, not a security operations treatment, not a corrections treatment, but a medical treatment. And as is the case in community treatment, our multidisciplinary team continues to work on ensuring that focus and ensuring that we have new training, new education for staff and residents, and that we respond to different situations that come up as this continues to be implemented and sustained within corrections. So as we expanded in 2020, we were hit, as everybody was, with a global pandemic. And so at the very onset of the COVID-19 pandemic, we made a commitment as a department to ensure that our medication-assisted treatment services did not falter and were able to be sustained at all costs during the pandemic. And we have been successful in ensuring that, albeit it has been extremely challenging, as it has been for all of our communities, for our individuals releasing into the community to ensure those continuity of services remain long-term. some of the things that we did as a department during this is we modified our medication administration protocols, which actually sped up our timeline to normalize our medication administration process in our facilities. But we did this in order to slow down movement in our facilities and obviously take into account all public health measures that were necessary. Along the way, we modified but continued our MAT induction processes, the ability for individuals coming into our system to continue medication-assisted treatment upon intake, and the continuity of care process upon release. Although our community treatment providers and partners largely went to telehealth services, we were able to capitalize on those telehealth services and technology to better support release planning and ensure the continuity of care was not negatively impacted during the pandemic. As such, we capitalized on a lot of these areas that allowed for efficiency and more normalization in our processes, and we plan to have many of these sustained as we go forward out of the pandemic. So as we approached 2021, and we're hoping that the light was going to be shining on COVID-19 pandemic and some level of normalcy returning to our processes, we conducted long-range planning for medication-assisted treatment services to figure out what was going to be next based upon our experiences and our lessons learned. And so we did a deep dive into our Maine data and what we learned pre-pandemic, what we learned during the pandemic, and the different experiences that we had along the way. And it was important that we focused this internally in the state of Maine because as many of you are aware, medication-assisted treatment services in corrections in general is still very early in developing what we consider to be best practices or an evidence-based practice across the nation. And so we really are relying on our experiences, our data, and our outcomes to guide what we do for our next steps. And so through our partnerships with outside treatment providers and access to that information along with our internal data, we've been able to do that as we go forward in 2021. We've also matched that up with policy recommendations from national stakeholder groups and national agencies such as the National Governors Association, Office of National Drug Control Policy, and other external groups that we consider to be partners in this work as we continue to forge the path. So as we move forward into 2021, what our plan has been, and as that we've been embarking upon for the last 6 months, is first a new wave of expansion that has encompassed those 1 year to release. We have now put in place mechanisms to continue the use of methadone medication upon intake into our facilities and provide that level of treatment to individuals, as well as planning for new inductions of methadone treatment going forward as part of our MAT services. As Commissioner Liberty mentioned, part of our 2021 plan also includes complete universal access to MAT for all eligible residents deemed medically appropriate, which is a significant step forward for the Maine Department of Corrections, but really corrections in general, making access that available. And finally, normalization of MAT services, which I will go into a little bit more detail on here in the next slide. So really one of the department's goals in general for 2021 and 2022 is really solidifying what we consider to be our main model of corrections, which is focused on a culture of wellness, ensuring that our services that we provide, all of the services that we provide, are aimed at making individuals in our care and custody better and helping them fill in any gaps that they come to us with, helping them address any needs that they have prior to release back into our Maine communities, with the ultimate goal of them remaining in the communities and having stronger Maine communities when they return. And so that has led to a deliberate effort specific to medication-assisted treatment services to normalize MAT in corrections, to normalize how medication is administered to individuals receiving MAT in corrections, so that it's not viewed as a security procedure to receive your medication. It is not viewed as significantly different than other medications and other medical treatments. And so we've embarked upon that in 2021, which has largely been supported by our lessons learned during COVID-19 and the shifted facility operations that we've had to endure. And it allows us to build upon what I referred to as the Maine model of corrections. Because another staple of this model to normalization is humanization, we've also emphasized language matters and the importance of destigmatizing incarceration, substance use disorder, opioid use disorder, and the need for treatment and the role treatment plays in individuals' lives. And our effort to destigmatize all of these components is an effort to really humanize individuals in our care and custody and help empower them during incarceration, during treatment, and shifting back out into the community. And so finally, I want to just recognize this is a significant philosophical shift for Maine Department of Corrections, but also corrections in general. But under Commissioner Liberty's leadership, we really feel that they're critical elements that are necessary for corrections if we're going to make sure that services such as medication-assisted treatment are solidified in individuals' lives and sustained as they release out into the community. And so shifting how we look at the medication, shifting how we do these processes in our facilities has been critically important, and it represents what I consider to be a promising practice in corrections and a promising model for how we can do this going forward. So with that, I would like to pass this over to Melissa Caminiti to discuss where we are heading further in more detail in 2021, including a lot of the key partnerships and projects that we have underway. Melissa?
Thank you, Dr. Thornell. So our strategic planning process and our move toward universal access and normalization have evolved in part through work that we're doing with researchers at Yale University. The work is part of a 3-year change project that's focused on breaking down silos and bundling services for OUD, HIV, and hepatitis C. We're one of 6 states participating in the project and one of 2 correctional groups. The project uses learning communities and individual coaching using NIATEX methods of small tests of change. For those of you who aren't familiar with the NIATEX methods, it's an evidence-based process improvement system. It was developed by the University of Wisconsin, and it really focuses on improving care in substance use disorder settings. So for us, one of our first small tests of change was related to the prescription monitoring program. We started using that to really proactively begin to identify individuals who are receiving MAT in the community so that we could provide a seamless care for them when they came to us. So starting them immediately on MAT. We also started using it so we could identify people who might have had a lapse in their MAT while they went through the systems, again, so we could get them started as soon as possible once they came to us. One of the other small tests of change that we did, it was more of a more significant test of change, was moving from a secure, more secured line to a normalized MAT medication delivery process. As we did that, we pulled together stakeholders from security and WellPath to meet from each facility to meet in a large group and really talk about what the normalized process might look like. We then charged each facility to go back to their local groups, really look at what normalization would look like in their setting and to break down those steps and come up with a plan to test it out in a unit or a pod and learn from that, see what went well, what didn't go so well. We came back as a larger group, shared our lessons learned, and we had several iterations of that where we continued to unroll the normalization in smaller units. And then eventually we unrolled it throughout the state. And so this process of small tests of change really worked in helping us learn as we went and really get to that place where we were able to deliver the medication in a normalized process. Can you advance the slide, Ryan? Thank you. So the other piece of our project involvement with Yale has been really a robust data dive and engagement in a strategic planning process. And one of the things that we did is we took all of our residents and we looked into our data to find out how many of them had an opioid use disorder. We then again, broke that data down into smaller and smaller pieces so that we could look in a stepwise fashion and determine what it would look like for us to open services universally to everyone who was medically eligible and appropriate to receive it. So we, in our strategic planning process, came up with a plan to open access to MAT services over the course of 2021. So our first movement was in February, mid-February, where we opened the eligibility window from 6 months to 1 year from that earliest release date. Then in May of this year, mid-May, we opened the eligibility window from 1 year to 2 years. We also began inducting residents who are actively receiving treatment for hepatitis C, regardless of their sentence length. So again, going back to that Yale project, bundling our services, breaking down those silos. So that was one of our first steps when we looked at our data to operationalizing it into actual practice. So when we initially envisioned our strategic planning, we had 2 other steps before we got to universal access. But as we've gone on and as we've approached our dates, we've realized that we think we're ready to go to straightforward into universal access August 1. So that is our plan right now. When we get to August 1, we will be opening eligibility to any medically appropriate resident, regardless of their sentence length. So we know that it will still take us a number of months to get through adding everyone into MAT services who is appropriate and wants to engage in that service. It is a voluntary piece there. We don't make anyone participate if they don't want to. It's completely voluntary. We know it will take us a few months to get everyone on, but we know we're also moving in the right direction. One of the other small tests of change that we have been looking at is shared medical appointments. So figuring out how to kind of get folks into a shared system so that we can manage the flow and the volume as we increase our numbers. So, and then in talking about numbers, prior to our expansion in February, we had a number of months where we held steady with 200 participants, plus or minus a little given who came in and who was releasing, but we were very stable at 200. Currently, we have over 400 people, so we doubled our participation since February. And by the time we're done, we anticipate that we will have well over 600 enrolled in our MAT services. So in terms of, I just want to give you a little bit of a flavor of what we do for education with our residents. So each resident has an initial MAT visit. During that initial MAT visit, they meet with a provider. There is a shared decision-making process used to try to really individualize care and make sure that the medication selected for each resident is appropriate for them and their treatment goals, and medically appropriate for them as well. In addition to getting education during their initial MAT visit, MAT nurses and nursing staff are available to provide follow-up answers to questions, to provide literature as requested and as needed. We're also working with an intern from the Tufts Medical School who is working with us to create a shared decision-making tool and an MAT overview guide that can be given to residents prior to their initial MAT visit. So they'll be coming into that visit with a little bit more education and information. So prior to induction, which is when folks start their medication, they do have a nursing touch point where they learn how to take the medication properly, which is particularly important for sublingual medications, making sure that they don't swallow it, that it remains under their tongue so they get the full effect of the medication. We also talk with them about what symptoms and side effects that they want to look out for and report to medical if they have any issues. We want to make sure that we're knowing about them and responding to them appropriately. Prior to release, they get education on Narcan, when to use it, how to use it. We provide them with literature that is for themselves and also for family and friends. And we encourage that it's a harm reduction method. We trust that they're can maintain on their recovery, but we want to also give them the tools that they need. So, and as Ryan mentioned earlier, every resident who releases from us who is on MAT does leave with a Narcan in hand. So the medications that we have available are buprenorphine products. We have both the sublingual daily tablets And then we have access to the long-acting buprenorphine injection. We've not yet used that with anyone. We have a couple of people who've recently expressed interest, but it is available. We also use naltrexone and Vivitrol. Naltrexone is a tablet that can be swallowed. Vivitrol is the injectable form of that. And the naltrexone and Vivitrol can be used for both opioid and alcohol use disorders. So a little bit different than buprenorphine, which is used primarily for opioid use disorders. The final medication that Ryan spoke about earlier, methadone, currently we only offer maintenance on methadone. So if someone comes to us from the community, from the jail on methadone, actively on methadone, we continue them on that. We are working very hard to get to a point where we can begin offering methadone inductions. So we are researching a couple of different things. We're researching whether we want to have an OTP within the walls of our facilities, or whether we want to contract with existing facilities in our state. So that research is actively being conducted, and we'll hope to have more information about that in the future. So continuity of care is very, very, very important. And I know we've talked about that. I think each of us now have spoken about continuity of care and how important it is. We have weekly release calls at each of our facilities. At each of those calls, we look at residents who are 4 to 6 weeks from their release. And I just want to say a lot of release planning pieces are in the works before that 4 to 6 weeks, but at 4 to 6 weeks, we come together as a team and start discussing these folks as a team. The topics that we look at housing, where they're releasing to. We know that's a really important piece of getting them stable in the community. We look at medical appointments, PCP appointments, mental health appointments, med management, whatever appointments might be needed. We look at those MAT community appointments. Our outside window is 7 to 10 days. We really try to get folks in within that first 3 to 5 days. We look at release medications needed, in particular, their MAT medications, making sure that they have enough to get them to that first appointment. And then we look at connections to the recovery community and employment or education needs. So I'll talk a little bit more about recovery community in just a sec, but the people who participate in those calls are myself as the director of MAT. We usually have an MAT nurse or a pharmacy nurse on the call. We have from the DOC, we have the director of evidence-based practices, and we have the correctional care and treatment workers. We also work with Groups Recover Together and with Day One. Groups Recover Together is at 4 of our sites, and Day One is at 1 of our sites. And they're really, really key in helping us with those community MAT appointments. They really help make sure that we have those folks in care with a solid appointment before they release. We also work again with the Portland Recovery Community Center, and their program coordinator makes sure that anyone who is interested in a peer recovery coach gets a connection to someone in the community that they're releasing to. And it's not just for Portland, it's anywhere in the state. And what we have tried to do is have a warm handoff for anyone who is interested in a peer recovery coach, so that they know who will be waiting for them when they get into the community. So that's been a great collaboration as well. So wanted to share a little bit of data with you, continuity of care data in particular. So for community MAT appointments, when we first started, we weren't doing the weekly MAT release calls at all sites. So it took a while to get those sort of up and running. It was a little bit bumpy at first. So we, in our first 6 months of providing MAT services, we had about 89% of those who released had a solid community appointment scheduled for them before they released. There were a couple of people during that time who chose to set things up on their own, and that was okay. We really try to partner with residents. We want them to be proactive and engaged in their care, and we want to support them by making sure that they do actually have solid appointments in place. So in 2020, 99% of our folks left with a community appointment scheduled for them at the time of release. And so far in 2021, 100% of those who have released have had a community appointment in place. We do, say to people, if you don't like your provider, if you have a different plan in place, you're welcome to make those changes after you release. But we really want to make sure that we're getting people in that first 3 to 5 days if possible, because we know that's a really vulnerable time. And so we work hard to make that happen. Of those people who release from us, 68% make it to their first community appointment, and the average retention in treatment that is about 149 days, so around 5 months. After that, it becomes a little bit harder to track. It's hard to track anyways, but we do know that. And just to give you a sense of what the numbers that we're talking about, in our first 6 months, we averaged about 19 people releasing per month from our facilities, from all of our facilities. And then in 2020 and 2021, we've had 35 or 36 per month who are actively prescribed MAT releasing from our facilities. A majority of our releases go to Penobscot County, Cumberland County, and Kennebec County. So kind of Bangor, Portland, Waterville, Augusta tend to be the areas where we see folks going to the most. And then lastly, I just cannot stress enough how important staff education is. It's really important to identify staff members who can be champions and early adopters of change. Staff people are the ones who will carry the message. And so we have tried to make our education more and more robust. So some key points that we really try to focus on are that addiction is a chronic disease, symptoms of opioid use disorder, how does that differ from criminogenic thinking, really trying again to focus on the medical parts of addiction and of opioid use disorder. We talk about the medications we use for treatment. And then we also talk, I know Dr. Thornell mentioned this already, but the language matters, attitudes matter, and stigma can have an impact on treatment trajectories. So we really try hard to focus in on that and help people look at individuals with addiction as people in recovery, as people who need support, and to make sure that that's a key part of our message. Some of the formats that we use, we have staff orientation, we have post-school for corrections officers where we have information about MAT services right there, right from the start. We use memos, emails, webinars. I attend staff meetings on request. We also have ongoing just-in-time education. So when people are asking us questions, when people are sending emails, if we hear something that doesn't sound quite right, we try to respond immediately and quickly. One of the key things that we've learned is that people are really interested in our outcomes. They're interested in knowing like what impact is the work that I'm doing having on people. So we recently had a request to share some of our data, share some of the information that we had here earlier about how many people have gone through the program, how many people have community appointments once they release. So we're going to be working on doing that and trying to really engage and maintain commitment to the program through sharing of that information. So with that, I'm going to turn it back to Commissioner Liberty to wrap us up.
Thank you, Melissa. Great information. If I could have Ryan and Melissa come back out, we've received a couple of questions. And as you'd mentioned, Melissa, about the importance of educating staff and pivoting sort of culture and the way we've done business in the past and what's gold standard and how we can really make a difference in the lives of many of the incarcerated Mainers in our care. Ryan, what have you seen for other challenges as you have implemented MAT in the Maine Department of Corrections?
Thanks, Commissioner. And thank you, Melissa, for your information as well. The challenges have really been, internal challenges just in that part of the implementation process and really the cultural change that comes along with that process, not just with department staff, but also, provider staff, external stakeholders who we work with. It's really been about fostering communication, education, and information sharing to really find champions, as Melissa talked, to carry the torch of MAT services and to demonstrate the effectiveness of it. And so really, I think that would be the challenge that I would highlight the most is really overcoming decades of corrections perspective on Suboxone and other medications inside of our correctional facilities, and challenging staff to view them differently and support them in a different way.
Thank you, Dr. Thornell. And Melissa, I like your comments regarding finding champions to affect this change and finding those people that are of influence, that are respected as staff in the facilities to actually adopt this. And I think we did a great job of educating and moving those people along. Would you speak to a moment about you'd mentioned something about continuity of care, on the tail end sort of, but what about the importance of residents coming from county jails and the importance of the county jails doing their work and being consistent so that we can have good continuity of care from time of arrest to time of release and transitioning back into the community?
Yeah, that has been a key part of our work, making sure, again, when we talked about the Yale Project and the prescription monitoring program, that's been a great way to figure out what people are doing in the community so we can see when they come into our system, what happens with their treatment. And I think it's really important that we work with the counties to make sure that process is seamless when they come into us. One of the things that we have done when we have people going from us into the county is we have started calling the counties to find out what does their program look like, what do they need for a bridge medication, and through doing that we've really developed some great relationships, and we now can have people calling us to say, well, what will your process look like? And so I think that it's well known now that we provide universal access to, or we're getting ready to provide universal access to MAT, but that so there's more confidence. I think that people know that when they come to us, they will continue to get the services that they need and have started. So I think that building those bridges to the other treatment agencies that are providing treatment is really important.
I agree. I think we can all agree that the county jails are trying very hard to get behind this initiative, and in spite of the migratory sort of population they have, they don't have the duration of sentences. And I think the judiciary and the district attorney's offices appreciate the fact that they know that that these individuals will get the treatment and the assistance that they need as they transition. Ryan, we have time for one more question. We know that these investments, monetarily and time and effort, bear much fruit and are worth the investment. What exactly is the financial impact for these sorts of programs? What have you found for funding sources to assist us in this effort?
Yeah, absolutely. And the return on investment can't be overstated. It's significant, especially when we're talking about saving lives. When we embarked on this in 2019, we set a budget for our pilot program of $1.2 million, which was braided funding between Department of Corrections funding into our medical services contract, but also roughly 50% supported by the Office of Behavioral Health through the Department of Health and Human Services through their access to funding to support this effort. And so what we found in that first fiscal year is that we actually came in under budget, under $1 million to run the MAT services operation. As we looked at expanding into the second fiscal year, we set the budget at $1.9 million, again with braided funding across those two funding sources, and again came in significantly under budget in terms of overall cost. And what we found in order to do that is the time required by both medical staff but also corrections staff to administer this treatment was far less because of how we rolled it out, because we identified corrections champions, and because our medical staff championed it the way they did. It did not require the significant oversight, supervision, and day-to-day monitoring that we thought it was going to. And so we've been able to drastically save on budgetary costs. Going forward, we've also received support in our budget for the next biennial budget in order to expand, as Melissa talked, for access to methadone, which is the most costly process because of the structure needed to administer that medication. And so we anticipate that costing anywhere between $2 and $3 million to upstart, but then we will level off into a budget that's really about maintenance and sustainability of the services going forward.
Thank you both. I think we're about out of time. I hope that those of you that have participated in this discussion have been able to receive an enhanced understanding of what the Maine Department of Corrections is doing with our integrated healthcare provider partners, and know that we're committed to assisting those incarcerated Mainers in their journey to recovery. Thank you all for participating.
Thank you.
During college, I had a kidney stone. I had been dabbling in opiates up to that point, but that was the first time I was ever like admitted to a hospital and given IV morphine. In that case, something clicked internally for me where I, saw how good it worked, right? Because it works great. It's like I went from a 10 on a scale of 1 to 10 of physical and emotional pain to a 1, or a very low score. So almost immediately, I got into OxyContin. This is around 2001, right, when all of that, was really popular and really widely accepted. And, kind of like the common misconception was that these things weren't addictive. And what it did for me pretty rapidly is led me down the path of heroin use and then IV heroin use. And I went from a graduate of a decent college to living in like the Boston Commons, for example, being an IV heroin and cocaine user. And I spent some time like going into programs and trying different methodologies to get well, right? I was on Suboxone for a period of time. I tried Vivitrol for a period of time. And what I found was that the solution for me wasn't going to come from these medications or from outside of myself. I had been introduced to AA years prior. It was the last thing I was ever going to do. It wasn't going to work for me because I'm a heroin addict and a cocaine user, and whatever I was telling myself back then. Basically, that was the last thing I was ever going to do. It was the last thing I wanted to do, and it was what I was trying again at 29. And for whatever reason, it worked. I engulfed myself in recovery. I lived in an Oxford House in Portland, Maine, which is kind of a peer-run organization where people in recovery just hold each other accountable. They pay their own way. They pay their own rent, and as a community, they get well together or they fail together. So for me, it was very evident from the beginning how important that kind of community aspect is. I'm always thirsty for more. I want to, learn more about myself, learn more about, why it was that I used the way I did that seemed to be different from other people. What was the things that kind of made me tick? And, that's not something you just like discover one day and then turn your life around. It's like this, it's like, it can always go deeper. People in recovery meetings, when I used to go, they'd say things like, I have a life second to none today. And I'd think to myself, what are these people talking about? Like, what does that even mean? And today I get it. I have a life that's, customized to me. Like, you wouldn't want to trade it with me, but I'm not about to give it up because it's, customized to me. And, the choices that I've made over the years have given me the qualities of my life that make it so, perfect for me as an individual. And then, I have a beautiful girlfriend of 5 years now, possibly 6. I hope I don't get in trouble for that. And, we have 2 dogs together, and I'm a homeowner, and, life is unbelievable. This is all stuff that I never could have imagined, right? I was bottom of the barrel, opiate and cocaine user. I couldn't really imagine past the next day, never mind the past week, or month or year. I didn't have foresight for how good life can be when substances aren't making choices for you. So it's been an unbelievable experience, and part of what I do is I just say yes to life and to recovery, and when I'm offered, to do things like this, I say yes because great things happen as a result, right? And I only got hope from hearing other people kind of share about their stories, and I kind of said, me too. I think I'm like that. Maybe what they're doing will work for me or whatnot, or I haven't tried that yet. So, that's why I'm here, doing that for hopefully somebody who says, I was kind of like him, like maybe recovery is possible for me too, and maybe I should try some of the things that he did. So it's an honor to be asked to participate in something like this, and I hope that it helps somebody.
Hi, everyone. Thank you so much for joining us to spend a little bit of time talking more about the intersections and relationships between risk and protective factors for suicide and opiate overdose. So I'm Sheila Nelson. I'm the program manager for the Adolescent Health and Injury and Suicide Prevention Program. One of our roles at the Maine Center for Disease Control is that we oversee the Maine State Suicide Prevention Program, which looks at reducing suicide risk, preventing suicide across the lifespan. Before I go any further, though, I do want to give a really special shout out and a thank you to my colleagues who were really instrumental in pulling all of this together. So those are colleagues of mine, Tanya Nash and Rebecca Card from Public Health Partners, as well as Randy Schwartz from Public Health Partners, and my colleague at Maine CDC, Aaron Burke. So also, just by way of a little bit of background, some of the funding and support for this particular project, you'll hear me talk about some tools and resources that are coming out later on in the presentation. Maine was fortunate enough to receive some funding from the U.S. Centers for Disease Control and Prevention in collaboration with the Association of State and Territorial Health Officials, or ASTO, to allow Maine, as well as a few other states that have both relatively high rates of suicide deaths as well as relatively high rates of opiate overdose deaths, to do some expansion of our statewide infrastructure, as well as to really dig in a little bit to looking at some of those intersections between opioid and suicide deaths, as well as build up some of those cross partnerships so that we can look at prevention strategies that might be effective across both opioid overdose prevention and suicide prevention. So promise not to spend a ton of time on data. I'm sure you've already seen quite a bit of that today, but I do want to just give a little bit of a sense of the background of kind of where Maine is at around the issues of both opiate overdose deaths as well as suicide deaths. So this is data for both overdose deaths and suicide deaths over the last several years. And you'll sort of see that starting, back in 2014, although certainly we saw, a really sharp increase in the number of overdose deaths, we're also sort of seeing a trending up in the number of suicide deaths. And that's been true for, many years, 10, 15, 20 years at this point. So, and for a little while there, over the past several years, both of those lines sort of have risen somewhat together, again, with a little bit of a gap, but we've been seeing, year over year increases for both deaths due to overdose, specifically deaths due to opiate overdose, as well as deaths due to suicide. Interestingly, in 2020, I know there's been a lot of, speculation and wondering about what the COVID-19 pandemic has done around both overdose and suicide. We're seeing a pretty clear pattern around overdose deaths. Certainly, we saw a really dramatic increase from 2019 to 2020. In Maine, we saw actually a slight decrease in suicide deaths, which we're not sure if that will become a new trend in a decrease. That would be great if it did, but certainly in 2020, we saw a slight decrease again from 2019 to 2020. So as I think folks have probably already heard quite a bit of today, 2020 was a particularly devastating year in Maine for drug overdose deaths. We saw a really pretty significant increase from 2019 after having had some success in lowering the number of deaths the years before. And we also know that, again, opioids continue to play a really significant role in those substance-related deaths, specifically looking at, obviously, fentanyl and heroin and other agents that are contributing to many, many, many of those deaths. In terms of who is dying as a result of drug overdose, again, this is all drug overdose, but recognizing that we are continuing to see opioids as playing a pretty significant role in these numbers. When we look at age, the folks who die by overdose tend to be sort of in early to mid adulthood, right? Primarily, starting at age 25 through the age of 60. And also, really significantly, primarily, those overdose deaths happen among men. So this is just a little bit of a comparison in terms of what we see in Maine for data around suicide deaths. Recognize that for suicide deaths, much like with opiate overdoses, those overdose deaths are sort of just the tip of the iceberg. Many, many, many more non-fatal overdoses that either show up in our healthcare system, come into emergency departments, or maybe are not even coming to the attention of healthcare providers. They may be managed at home. But certainly in Maine, we had 224 people in 2020 who died by suicide. Again, recognizing that many, many more people may make a non-fatal suicide attempt or have a suicidal crisis or some other sort of suicidal event that does not result in their death. Although Maine's numbers can sort of bounce around a little bit from year to year, that's largely, a result of the fact that our overall population numbers are not huge in comparison to other states. Maine does tend to have a suicide death rate that is consistently higher than the national average in almost all years, and that typically is among the highest in the Northeast. And so although these charts look a little bit different because the way that we break out the age categories for suicide deaths is a little bit different than what you saw on the slide earlier. The patterns around sort of who largely in Maine dies by suicide and who dies by opiate overdose are not super dissimilar. In Maine, suicide deaths are much more likely to happen in sort of a mid to late adulthood, with the exception a little bit for us that we do see a fairly substantial proportion of suicide deaths in Maine being among adults older than the age of 65. But also, somewhat similarly, overwhelmingly, folks who die by suicide tend to be men. That said, with the caveat, as I sort of said, these are the tip of the iceberg. Women in Maine and across the country tend to actually experience much more suicidal behaviors than men. So they're more likely to make a suicide attempt or have a suicidal crisis. One of the reasons that we see this particular pattern around suicide deaths is that men are more likely to use a method to end their life that actually results in their death. So more likely to use, for example, a firearm as their method of suicide. Whereas other genders tend to use methods that may allow for a medical intervention that in fact ends up saving their life. So this is sort of the big picture that we want to dig into a little bit as we sort of go through the rest of our talk. And that is really looking at, okay, we've been working really hard in the state of Maine to prevent opiate overdoses, and we've been working really hard to prevent suicide deaths. In fact, though, as we just saw with those, real overlap to some extent in the populations who are experiencing the highest disparities and the highest burden of overdose and suicidality, there are actually other sort of overlapping, systems around risk factors for both overdose and suicide, as well as potentially some of those protective factors that we might be able to use to target for some of our prevention work. So when we look at some of these risk factors, and I'm sort of joking about risk factors at the big picture level, right? There are certainly individual level risk factors that are unique to a certain person, and that's sort of their own constellation of history and circumstances that may raise or lower their risk for an overdose or suicide death. But when we look sort of big picture, many of the same sort of large buckets of risk factors apply to both suicide and overdose. The first one of those is really looking at, again, the biggest of the big picture factors, the real structural underlying, something we might sometimes refer to as the social determinants of health. So those are things like access to safe and affordable housing, access to education, and the ability to have a livable, supportable wage. Again, those are things that we know, for example, as folks have increasing levels of education, their risk around substance use and suicidality tends to decrease. Likewise, one of the really interesting factors that we've seen, certainly as it relates to suicide, is that as folks' economic, place or systems tend to improve, their risk for suicide goes down. There was actually some really interesting research that really showed that with every dollar raise of the minimum wage, that suicide rates in the communities that had raised those wages tended to stabilize or reduce in direct proportion. And I know certainly when we talk about economic instability, we certainly see that as a sort of a significant risk factor for overdose as well. Recognizing that these things can be a little hard to pull apart chicken and an egg, certainly having an ongoing substance use disorder or a chronic and untreated mental health condition may make it really quite a bit harder to have sustained employment or have housing that remains stable. But we do know that the factors that improve these big picture conditions for folks, again, in the long run, on a population level, improve well-being and reduce the risk around suicide and overdose. Just sort of moving down a little bit of a level from that really big picture stuff, looking sort of a little bit more going on at the individual, we do see that unmet mental health needs, unmet needs in general around physical or other well-being indicators increase individuals' risk around both overdose and suicide deaths. So we certainly see, as I think folks who work in the overdose prevention field will be the first to tell you, a lot of what we sometimes refer to as co-occurring disorders. That means substance use and another mental health diagnosis or multiple mental health diagnoses, and also potentially a physical health issue as well. Some of our data from a project that's called the National Violent Death Reporting System, which collects data on sort of circumstances associated with a death by suicide, has shown in Maine one of those leading circumstances is actually an underlying physical health problem, as well as a potential for a history of mental health or a behavioral health need. So we certainly recognize that very rarely do folks who walk through our door looking for help around recovery for opiate use or recovery around mental health walk in with just one thing that they're carrying with them. It's often a really complicated picture that may in fact be sort of a multiplicative effect, right? The more folks have going on, the harder it can be to get adequate services and move into recovery. We also recognize the huge role that trauma and adverse childhood experiences have for folks who may have a substance use disorder or be struggling with their mental health. Issues around trauma come up constantly, certainly in my work, and I know they do for folks who are also in the harm reduction and recovery space as well. And sort of moving again back out a little bit from just that individual level, we also sort of see the kind of community and the social support networks of individuals playing a really big role. We know that sort of the fewer supportive connections that folks have, not only does their mental health tend to be quite a bit worse, but they may have sort of fewer, buffering factors against a suicide or a potentially fatal opiate overdose, when folks are, using opioids in isolation, or when folks are really struggling with their mental health without anyone else with them, or connected to them and invested in their well-being, those are not situations that are often very safe for folks. We also certainly see a lot of overlap in this kind of populations at increased risk. I can speak most, specifically around some of these populations, being communities that bear a really disproportionate risk around suicide. We see for veterans, certainly for individuals who are LGBTQ, as well as folks in indigenous communities, and again, those who may have experienced childhood trauma. Those are predisposing, factors that may increase somebody's risk for suicide, death, and potentially for opiate overdose. I want to be really clear, though, there's nothing inherent in being, a member of a particular community or having a particular identity that puts someone at risk for a suicide, death, or a fatal overdose. These are communities that are often experiencing high levels of social stigma, who may have experienced, sort of historical trauma and genocide, who may have really significant struggles around post-traumatic stress disorder and other things like that, that again, may increase their underlying vulnerability. But that's really about, again, sort of social factors that may predispose communities to having increased risks. On the flip side, when we talk about risk, and sometimes, I wish we started off here rather than starting off with all the risk stuff. When we think about the stuff that is protective for folks, that increases resiliency, that really buffers against harm and promotes, recovery and other sort of health promoting practices, as you can imagine, sort of tracks back a little bit to when we talked about the risk factors. Many of these are sort of the inverse. Certainly, enhancing connectedness at all different levels, whether that's in a geographic community, a family network, any sort of identity-based, support systems that folks have, as well as potentially in recovery communities or group settings or things like that. Those, the strengthening of those emotional supportive connections is really a sort of a critical factor to keeping us mentally healthy and to promoting, again, some of those positive self-care behaviors around our mental health and, and substance use patterns. Likewise, for folks who, may be experiencing some medical or behavioral health issue, we need folks to get connected early on to effective evidence-based interventions that directly address suicide risk or substance use disorder and overdose risk. So specifically, I think for many years in the suicide prevention field, sort of assumed that if you just treated an underlying mental health disorder, that suicidality would go away. Similarly, I think we used to think that, if we treated a mental health disorder, that someone's substance use disorder would go away, or vice versa. And what we now know from all of the evidence is that, in fact, we really need to take a very direct approach to treating suicide risk from a behavioral health perspective, as well as treating substance use risk from a behavioral health perspective, again, with those evidence-based treatments that we have documented to be effective. A big piece of that, certainly around overdose prevention, is medication-assisted treatment. And similarly, for mental health, we know there are evidence-based treatments that directly reduce suicide risk, and also medications that may help folks manage those experiences. Sort of simultaneously, we really need to be looking at those underlying community conditions, folks' access to stable housing, affordable health care, economic security. I think it's taken our field a long time to think about those as, as a public health intervention. But in fact, we know that in many ways, we can sort of put all of the, recovery supports and treatment resources, that we put into somebody's life. If we can't improve their sort of basic human needs or can't address those basic human needs, it's really hard to get folks into a place where they're able to care for themselves otherwise. So taking all of that, again, thinking about the fact that we're seeing all of these overlaps, both in populations that are affected or at risk, and in some of those underlying risk and protective factors, we sort of want to make the case that this is a really good reason to start approaching, both suicide and overdose, prevention from a sort of combined perspective, from really putting our energy into those prevention practices that, for lack of, a different cliche, that give us basically bigger bang for our buck, that really address those systematic factors, those, social determinants of health and other, sort of upstream risk factors, that if we can make a difference there, we may potentially be making a much bigger difference in folks' lives, a much more sort of cross-cutting difference in folks' lives later on in their lives. So I'll talk a little bit about some of what are our best practices for prevention. Most of what I'm going to talk about for prevention is really on what we would consider in public health, the kind of primary prevention side of things, the upstream prevention side of things, the things that we can do before folks really start to struggle around suicide risk or potentially around overdose risk. That said, I do want to take a minute and just, say briefly that anytime we're working with an individual who is at risk for a substance use disorder or has a substance use disorder, or if we are working with someone who is at risk for suicide or struggling around their mental health, we 100% need to be assessing and screening to make sure that we're catching everything that's going on with that person in front of us. You sort of saw in those earlier slides, right? Pretty high likelihood that whoever we're working with is coming in with a pretty complicated, sort of menu of concerns going on for them. And frankly, any individuals experiencing a substance use disorder may potentially be at risk for suicide and vice versa. Substance use can contribute to suicide risk in a number of really complicating ways. Folks who may be consuming a substance that impairs judgment or reduces sort of inhibition, that can be an incredibly dangerous place for people to be in if they are struggling with thoughts of suicide. Likewise, individuals who are struggling profoundly with their mental health, who are in extreme, mental distress, they may be using any number of substances in order to try and manage that experience or to try and cope. Or their substance use disorder may be sort of interacting with their mental health in a way that is sort of worsening the entire picture. So we really encourage you, even if you're somebody who sits in the harm reduction recovery sphere around substance use, if you are working with someone, please, please, please screen that individual for their suicide risk. We have a screening tool that we recommend called the Columbia Suicide Severity Rating Scale. 6 questions, don't have to be a licensed clinician to use it. Really, anyone can. It's just a way of sort of raising some of the questions in a structured way and also assessing, someone's really sort of level of risk of harm. Someone who is really having a hard time in their life for any number of reasons, they may have occasional thoughts of suicide. Certainly something that needs to be addressed. They need to get support for it. But what we really want to do is quickly identify individuals who really may have very high level of risk. So have a plan for how they might end their life, the means to carry out that plan, who may have actually taken steps to do so. Likewise, if someone is, really coming to us around suicide risk, we need to take into account whether or not they may also have a substance use disorder, both to make sure that they are getting the appropriate care, but also because, if we're trying to manage their suicide risk and we're not taking into account the role that substances may be playing in their safety or lack thereof, we're potentially not doing a good job in planning for safety with that person. I'll fully admit, I know there's many sort of substance use screening tools. Since I'm kind of coming a little bit more from expertise in the suicide prevention field, I didn't put up a tool specifically around substance use screening because we don't have one from our program that we would specifically recommend. But I would really encourage you to reach out to your colleagues or to look into your agency policies or other work that you do to figure out a screening tool that's easy to use, not super burdensome for you or the folks you're working with, but that can really give you a full picture of what might be going on for folks. So that's the individual level stuff that I will say. Again, from a public health perspective, we're always going to want to kind of go upstream a little bit. So what I'm going to go through on the next couple of slides are some of those sort of high value prevention strategies for both opiate overdose prevention and suicide risk prevention, as well as potentially a couple examples of programs that incorporate these strategies that we have used here in Maine. If you're interested in more information about any of these, you can reach out to us. I'm happy to connect you with the folks who work directly on these programs, or maybe they're ones that come from us and that we're happy to bring to your organization or community. So the first, sort of strategy that we look at is starting with teeny tiny kiddos, right? Like obviously, the earlier we can get to people before patterns and experiences that they have later in their life raise their risk for poor outcomes as adults, the better. So earlier is better always for all the work that we do. So one of these strategies, again, that's been shown to be really protective for both overdose and suicide is looking at promoting social and emotional learning skills. So these are basic skills, although they're often not very basic in terms of what it takes to develop them, but they're the things that we use every day in the ways that we negotiate the world. So things like emotional awareness, self-regulation, empathy, goal setting. So these are fundamental sort of, resilience building blocks for how we navigate the world and our relationships with other people in ways that are healthy and protective. And again, the better we negotiate our world, the better we create and establish and maintain those relationships, the more protective those social supports and connections end up being on later in our life. And so there's a number of initiatives that are really looking at, like, instead of just assuming that everybody figures this stuff out naturally, sometimes we do, often we don't. There are a number of programs that are now looking at how can we start, again, really little kiddos, pre-K kiddos, to start providing opportunities for young people to identify and practice those skills so that, we can apply them throughout the rest of our life in a lot of different areas. One of the programs that we work on here at Maine CDC in partnership with colleagues at NAMI Maine and the Maine Youth Action Network is a program called Sources of Strength. That one's actually aimed at adolescents, at teenagers, but it really focuses on taking a really holistic approach to well-being and building up those positive peer relationships and relationships with positive adults. Our colleagues at the Department of Education have done a great job in putting out free, developmentally staged, evidence-based curriculum lessons for school personnel, again, pre-K all the way up, that allows teachers, educators, folks who work directly with young people to really do some of that structured work around teaching social and emotional learning. And that's the SEL for Me platform. And again, if you're interested in more about any of these, feel free to connect and I can connect you over with the folks at the Department of Education. So moving a little bit further up the lifespan from kindergartners, as kids transition into adolescence, right, as they move into that developmental stage, we know that can be a period of time in people's lives where they may be engaging in more risk behaviors. And that's actually developmentally normal. We know that that's a big part of adolescent development, is to start exploring our world in new ways, to look for new experiences, to sort of build and experiment with peer relationships. That said, we also know it's a time when folks can sometimes develop patterns of use for substances or mental health patterns that may end up becoming unhealthy later in life. So we really sort of endorse and recommend strategies that work really specifically with young people to, again, help them build on those social and emotional learning skills, but also develop leadership skills, more peer and adult connections, and really to take an active role in engaging with the well-being of their communities. So the Maine Youth Action Network, which is a program of the Opportunity Alliance, which is our statewide youth leadership network, really encourage you to check them out. They have many, many awesome trainings. So even if you're an organization that doesn't directly do youth engagement work, totally encourage you to look those up. As well as the Maine Resilience Building Network. We'll talk about them a couple of times. So you'll see some of these organizations popping up more than once. But certainly the Maine Resilience Building Network, again, looking at what are those factors that we can put into place for young people in their communities, in their lives early on that set them up for success. So certainly we want to build knowledge, recognizing that although we wish we could, wrap every kid in a nice, safe cocoon, that's not always an option. Young folks experience trauma. They may have childhoods that, have experiences that potentially could result in later risk for, substance use or a mental health condition. And that we recognize that, but also recognize that, that doesn't mean that young person has to then go on to struggle as an adult, right? That many of us experience trauma. Many of us can be very resilient in the face of that trauma. And also that we as professionals need to do our work in making sure that the strategies that we use, the programming that we provide, the relationships that we foster with individuals who have a history of adverse childhood events or trauma, that we have done a good job of being trauma informed. So we really recommend that any organization that is working in the mental health or overdose prevention sphere really dig in around the impact of those adverse child experiences, how trauma does affect our behavior, and ways that we can really build resilience and recovery into the strategies that we use with the folks that we serve. I'm going to put the Maine Resilience Building Network up here. Obviously, again, they do a lot of really great work training technical assistance around adverse childhood experiences. And also just to flag the Prevention Technology Transfer Center. So there's also an Addiction Technology Transfer Center. So those are networks that really provide a lot of great evidence-based professional development on how to sort of, incorporate some of these concepts into our practice. Totally will put a plug in for data-driven decision-making here. Certainly when we're really kind of in the trenches one-on-one with folks, it can be really hard to figure out if what we're seeing is actually reflected in the larger community, state, nation. And if the trends that are showing up in front of us are showing up other places, and if so, like what are some of the more systemic approaches that we might be willing to take? So our program oversees the Maine Integrated Youth Health Survey. That's the statewide youth risk behavior survey for Maine. We administer it to kids in, in 5th and 6th grade, in middle schools, and in high schools. We do that every 2 years. It asks a ton of information about young people's risk behaviors. So certainly things around mental health, suicidality are in that survey. Things around substance use. We also ask a lot about protective factors and sort of assets in terms of family and community support that might be available to young people. Really encourage you to go check that out. Take a look at it, see what responses are coming in for your community or your county public health district, and see how you compare to the rest of the state. Also, we'll totally put a plug in for the fairly new Drug Data Hub, a really good place for you to be able to find a lot of the data that you've probably seen in other presentations or that folks have been talking about, in one place, along with a lot of really great resources and sort of other policy and programmatic work, so you can sort of see how this data directly connects to work that's actually happening at the community level. And then certainly, sort of want to flag for that really, again, grassroots community-based work to bring folks together across the spectrum to address some of these issues. I mean, we're really excited when, mental health, addiction treatment professionals are interested here. But because so much of this is, again, happens, in families, in communities, we want employers, we want faith leaders, we want, local government folks to be as engaged, to care as much about this and about these issues as we do. So we really encourage you, if you are not connected with a local public health coalition, a local substance use prevention coalition, we encourage you to do so. On the right there, you'll see the Maine Prevention Services. That's the sort of Maine CDC supported network of community public health coalitions that address a range of issues around substance use prevention, commercial tobacco prevention, youth leadership engagement, as well as things like healthy eating and obesity prevention for young folks. So definitely reach out and see who your local stakeholders are and how you could potentially get involved again with some of those, kind of community grassroots initiatives. And certainly, as we have, heard throughout the day today, and we'll continue to hear throughout the day today, there's a huge role of just sort of telling stories and fighting stigma, both around folks who may have experienced, substance use disorder, who may have lost individuals to overdose, as well as to folks who are in recovery around mental health or who may be suicide loss survivors. We always say that these are public health emergencies that, that worsen in the dark. And the more we can talk about this, the more we normalize that, yes, struggling around mental health, struggling around substance use is way more common than most people think. And that seeking support, seeking recovery services is one of the most powerful and courageous acts that anyone can take in their lives. We really want to just put this front and center. So we have some campaigns that we're running around sort of, again, helping folks identify when they may be coming up or at risk of a mental health crisis, and to connect to resources like the Maine Crisis Line. And, likewise, I see the, TV commercials get me every time I do around the options program. And again, really trying to hear the voices of folks who are in recovery or who may be supporting loved ones in recovery. So just a few sort of things to flag for you all going forward. Some of these are a little bit, coming attractions, coming soon, but we want to sort of put them in front of you so you'll know to go looking for them in the next few weeks and months. Certainly from our perspective, the Maine Suicide Prevention Program, we have finalized and have updated Maine's suicide prevention program strategic plan for the next 5 years. You'll see a lot of strategies in there that will look familiar to some of you who have read strategic plans or state plans around overdose prevention. Again, much of what we're talking about around primary prevention, increasing access to care, reducing stigma, all of those, again, same set of tools, that we're really trying to use to address both of these really critical public health needs. While we're talking about tools, in addition to that state plan, I'm a fan of plans. I love them, but, they only go so far. We really want people to use these resources to come up with things that are effective in their communities. We will sort of be including a set of tools that go with the statewide strategic plan around sort of how suicide prevention is relevant in a whole bunch of different community sectors, around some of those intersections between suicide and opiate overdose prevention, looking a little bit at the impact of COVID-19, as well as, again, real resources for folks, whoever you are, wherever you sit, and then some tools for helping you in your organization, community, school, network, do some actual action planning for how you feel like you can contribute to preventing suicide in the state of Maine. And again, these are all the same sectors. You know, this is where the work happens, right? We know folks at risk for opiate overdose, at risk for suicide. We are encountering them in every part of the community, right? We're seeing folks in our schools, certainly, you know, in interfacing with public safety, but also, you know, in employment situations, right? In local government, any number of places where we need everyone to really be engaged in these issues to help promote overall health and can get people connected to care. Also want to sort of throw out again another sort of a shout out and advocacy bump for the Maine Resilience Building Network. Those concepts of underlying risk and protective factors, again, are critical to doing the kind of upstream prevention we want to do around both of these issues. So please, if you haven't sort of dug into some of the research around ACEs, as well as some of the work that they've been doing around the concept of mattering, around how young people experience whether or not they matter to their community, I really encourage you to go and check those out. So I will stop here and thank all of you so much for your time. Thank you for being here. Thank you for, you know, again, your interest in prevention for both opiate overdose and suicide. And we really encourage you to reach out, think a little bit more, feel free to contact us, and that we really hope that you get a lot out of the rest of your day. Thank you.
I had just recently separated from a long 13-year relationship, and my son was, didn't see my son for months. I got into a deep depression. I didn't know that separating, even if it is a relationship that I didn't want to be in, it is a major life change. I didn't know that. So I got into a self-sabotage and mindset where I just went on a rampage for 9 months. I was really self-destructive mode. I pawned everything I had. I had an apartment and 2 part-time jobs. I lost the jobs. I started drinking or using drugs on a daily basis. I tried heroin for the first time ever, and I got addicted, instantly addicted to it right off the bat. I had no clue how powerful this drug could be. I didn't know that I could just, you know, surrender myself, right? Surrender myself to sobriety, right? And my higher power. And I didn't even know that that world existed yet. So I ended up getting arrested and then getting charged with trafficking originally. And then the best thing, honestly, that ever happened to me was being in jail for a year. That is the best thing that ever happened to me, because I was able to look at myself in the mirror and start to change what I had become. I started to go to meetings every day. The first 90 days, I went to 90 meetings in 90 days. And I'm pretty sure I did 2 meetings sometimes daily. I did everything I could possibly do to stay busy. I even walked to a meeting, and I walked to a meeting in a snowstorm. I can honestly say that. And it was like a 25-minute walk, but I did it, and I didn't hardly complain about it. I told the people in the meeting that I just walked that much, and they were like, awesome. So just kind of like being open and honest with people, and finding out and not being afraid to be myself has really helped me to overcome a lot of barriers that I used to hide from. you know, the scared inner child, right? The damaged inner child used to run away from people a lot. And I don't want to live that way anymore. I like being this way. I like being clean and sober. I like having a program. I love having a community of people. As much as people don't want to change, you got to make that change. You have to stop. You have to really close some people out of your life in order to start new. It's like being reborn again, really. For me, I noticed that I was lacking in my cultural aspect. So I started to go to Wellbriety more, and I remembered when I was growing up on a reservation how I used to speak my native language, and I used to go to powwows, and I have a lot of elders in my family that taught me like native ways, and moving away 12 hours away from them in a different country, I kind of lost that. So I realized when I was incarcerated that was very painful for me. That is where the pain was, that including other things that was going on. So that's when I realized I gotta heal myself. I'm so grateful. I know that I would have not had I would have not had the chance to do what I've done if I didn't choose recovery, if I didn't choose to live right and be honest with myself and others. I would probably be dead. And today I'm so grateful that I'm not. Today, if I'm stressed out, I will go to a meeting. If I'm stressed out, I'll go for a walk. I already know what I need to do. I have a structured routine during the week. I hit a certain amount of meetings. I still go to counseling. I see my sponsor regularly. I have people I help in recovery. I do some recovery coaching. I'm a certified recovery coach now. And I don't know, I haven't slowed down. I got a lot of things I still want to do.
Good afternoon, everyone, and thank you for your interest and participation in this breakout session on supporting families and protecting children. We're going to talk about a systems approach to strengthening families impacted by substance use, both before, during, and after the pandemic. So our presentation today is going to include our Office of Child and Family Services, also known as OCFS staff, presenting information on multiple different topic areas. My name is Christine Terrio, and I'm the Family First Prevention Services Program Manager with OCFS, and I'm going to be starting us this afternoon. So our goals for this presentation is really focused on sharing information about current OCFS initiatives that are being implemented to support and strengthen families who may be impacted by mental health and substance use and the pandemic. We also want to share some state and community collaborations that are underway that are meant to increase access, availability, and knowledge of the services that are available to Maine families. So for today's presentation, each OCFS manager is going to be sharing information about their program areas. And you can imagine that we have a lot of content to share, so we are going to save questions for the end of the presentations. So to lay the foundation for the presentation today, I think it's important to understand the role and responsibility of the Office of Child and Family Services as a state agency. Our staff work with professionalism and respect to support children and families in Maine, again, providing children's development, behavioral health, and child welfare services. We're really committed to early intervention services, prevention programs to support families, and we really want to help to support families before challenges even start for them or develop. And we really want to make sure that we're focusing on safety, permanency, and well-being for all of Maine's children. So in addition to this, we really want to focus on safe, stable, and happy and healthy families and children. So collaboration, both within OCFS as well as across the multiple state and community partners, is really important for us in moving forward with our initiatives. The knowledge and support of the initiatives that are underway within our program are important for you all to know about, so we can have your involvement as well as support in both state and community implementation of these programs, again, with our overarching goal to have healthy and safe families. So here's a list of the initiatives you're going to hear about today, and I'm going to start us off with talking about the Family First Prevention Services Initiative. The Family First Prevention Services Act is a federal law that was passed back in 2018, reforming the Social Security Act specific to Title IV-E. So Title IV-E is federal funding that has historically been provided to states to support placement and care for children after they have entered into foster care. The Family First Prevention Services Act modified this in that it provided states with an opportunity to receive federal funding support to prevent youth from actually entering into foster care. So there's two major focus areas, as you can see on this slide, for Family First. The first is specifically focused on prevention services for families, which has the goal to prevent the removal from the home by providing services and supports to families in which the children or the child is at imminent risk of entering into foster care. So as you can see on the slide, the services must be trauma-informed, they must be evidence-based, and we really need to make sure that they're focused on substance use, mental health, and in-home skill-based parenting supports, as well as kinship supports. So the other major arm of Family First is focused on improving the quality and appropriateness of residential treatment services for those youth who do need to enter into foster care. So the Family First law specifically established quality standards for residential programming. We'll talk about that in just a moment, but the standards are in place to not only improve the quality of care of children who are placed in these programs, but also reduce the number of youth who are placed in group care settings. So as you can see here, the Family First initiative is actually part of a bigger puzzle of many initiatives that are going on across the state and the department. And we are one piece of that puzzle, but we've worked very collaboratively with other programs that you can see listed here to make sure that our initiatives are aligned. Again, all of us that are working within these initiatives are working towards the same goal of strengthening and supporting families and making sure that we're not duplicating efforts, but we're working together. So in preparing for Family First, we've worked with our stakeholders, both community and state partners, youth and parents. We've also reviewed data to get us to this place where we've developed a draft plan for how we will implement Family First. So as you can see on this slide, this is sort of our preliminary plan for how we will implement Family First. Again, it's still pending approval from the Children's Bureau, but OCFS is going to identify the candidates for receiving Family First services after a suspected report of child abuse or neglect is received and investigated. So following federal law requirements, we've worked very closely with our staff and our stakeholders, again, with youth and parents to identify what our definition for candidacy and eligibility is going to look like. So as you can see in the first column, our candidates for these services are going to include a child who is a victim of maltreatment, in which safety and risk factors can be mitigated by the provision of in-home services, and they're able to safely remain at the home with a child-specific prevention plan. Also, pregnant and parenting youth in foster care are eligible for these services, which is something the federal government has pre-established as eligibility. And then also we've determined that children who have exited foster care through either reunification or guardianship or adoption, and they may be at risk of re-entry into care, would also be eligible for these services. So in order for us to be able to, a family to be able to receive these services, the family has to be involved with child welfare services. The children have to be at imminent risk of being removed from the home. And again, identified as that without those prevention services, they would be at risk of entering into foster care. So the middle column focuses on the services, and I've already kind of highlighted this earlier on in the introduction part. But we have to select specific evidence-based programs that fall into these categories. The services are time limited to 12 months, where we would have to reestablish whether or not the eligibility still exists. And these services cannot already be funded by Maine Care, so we cannot use federal dollars for 4E to also pay for a program that Maine Care is already funding. So in just a moment, I'll share a little bit more about what these services look like. So the final column on the slide talks a little bit more about how we're going to implement this. So existing practices of structured decision-making, the prevention services, family plan, family team meetings, all of this would be identified, the services and supports and the needs for the family would be identified through these processes. So the plan would be developed and reviewed every 90 days with the ongoing monitoring of safety. So OCFS has selected a couple of programs to develop through Family First, while at the same time focusing on the services that are already existing and being built across the state. There's several initiatives, as I mentioned earlier, where some of the existing programs are being expanded so there's more providers across the state, such as programs like Incredible Years and Triple P and parent-child interaction therapy, as well as trauma-focused cognitive behavioral therapy. So these services and supports are going to be important to educate not only our staff, but other providers across the state about what is available and what's out there for families. So the two new programs that we're looking to expand and bring to the state as part of Family First is the expansion of the Parents as Teachers program. We're looking to expand that program to cover children ages 0 to 5. We know that a majority of youth entering foster care are between the ages of 0 to 5. So this is really focused on that group of youth. So the Home Builders program is a new program that we're bringing to the state, which is a family preservation and reunification program. Again, doesn't already exist in our state, but we're looking to build that and have families have that as a service available, again, to prevent the need for foster care. So I want to highlight again that making sure that although there's only 2 programs that we're able to bring to the state through this initiative through federal funding, there's plenty of other opportunities to educate and bring to light and work through other initiatives to make sure that families are aware of the services that are out there to help support them. Again, we're all working towards the same goal to keep children in their home and support families. So one of the opportunities that we have to increase that education about the services and supports that are available is an initiative we're working on for a family services resource guide. So this is a guide, a high-level guide of information about programs and services that are out there for families. That'll be a web-based tool. We're working with other state agency partners, again, to not duplicate efforts, but to make sure that there's information in the guide about treatment, recovery, other basic needs, and those kinds of things. So it's going to be really important, again, that we share the information with families, with providers, with our staff about what's out there to help families. And at the same time, I feel like we're going to learn about the gaps that might exist throughout the state of areas that we might be able to fill throughout this initiative and the other initiatives, as I mentioned earlier. So another important goal of the Family First Prevention Act, as I mentioned at the beginning, was establishing these quality standards of care for youth who do need to enter into foster care and be placed in a residential treatment program. Again, the goal is reducing the number of youth in group care settings, which Maine has done a very good job at that over the years with having a low number of youth in residential programming and group care settings. Across the nation, it's been more of a problem, which is why this has been incorporated into the Family First Act. So beginning October 1st, children's residential treatment programs must meet this the criteria that you see on the screen in order for states to be able to claim Title 4E dollars for supporting the room and board for that placement. So the youth must have a 30-day assessment, treatment level of care assessment, to determine whether or not that placement is appropriate and whether or not the level of treatment is appropriate for that child. That's a definite big difference. But the rest of the items that you see on the screen are more changes that residential treatment programs would need to make, including enhancing and the family engagement part, making sure that siblings are involved in the treatment process, being trauma informed, having nurse and clinical staff available. It's also want to highlight this very important change of aftercare support. So as part of this new law and new kind of standards, 6 months of aftercare support will be provided to families and the youth after they have been discharged from the residential program, which is a huge opportunity to transfer skills from the program to the community and to the home setting, and provide support to the family to make sure that that return home is safe and also successful. So lastly, I just want to provide you a quick update on our next steps. So every state is required to develop a state plan for how we're going to implement Family First. We've submitted our state plan in February, and we've had some revisions that we've made to it, still pending approval, but we are the first New England state to have submitted our state plan and hope to be the first to have it approved as well. So we are going to be disseminating a plan through a webinar following that approval process. We're going to again work towards implementation of Family First starting October 1st, working over the summer months to educate our staff and to build these programs up as we need to. We're going to continue to engage youth and parents and other stakeholders in the work that we're doing. You'll see on this slide a list of some of the stakeholder groups that we have currently going on that will again help us to identify some of the, or address some of the major issues that have come forward, such as the workforce, behavioral health and supportive services workforce, and trauma-informed care. So we're going to be continuing to work with Maine Care and licensing on the qualified residential treatment program standards. And again, full implementation of this is expected for October of 2021. So that's it for Family First. I'll now turn it over to Bobby Johnson, who is the Associate Director for Child Welfare Services, to talk about those initiatives.
Great, thank you, Christine. And it's my privilege to be here today, to be participating in this summit and to be able to share information with all of you about the child welfare system and the child welfare agency. So within OCFS, we have the child welfare agency, and within our state and our communities we have the broader child welfare system. The agency could not do our work without partnership with the family, including parents and children and relatives, and then all of the various community partners that help to support families that are within our state. So the state agency partners, schools, our DV sexual assault providers, our substance use disorder treatment programs, our mental health and behavioral health programs, housing, foster and adoptive and kinship families, law enforcement. There's just a variety of different stakeholders that really form the circle around these families to help them be successful and provide support. And I wanted to start with just talking about the 3 primary functions of child welfare services. And so the first is child protective intake. And this is the part of our system that I think a lot of people are familiar with. It's our child protective hotline, where mandated reporters and other community members, relatives, friends, neighbors can call in and report suspected child abuse and neglect. And you'll see the hotline number there. We have done a lot to improve the services provided by our intake programs to decrease the length of time a person has to wait to make a call. And we have things like, we have the first in line where we can call you back if you aren't able to wait at that time. This is really one of the places, this is our first, the first time that we are learning about families that may be in need of child welfare services. And some of these families, some of that intersection with substance use disorder is related to parents struggling with substance use disorder, substance exposed infants, which you'll hear more about from Dr. Carmack, who will present later, ingestion. So children that are are getting substances and ingesting them, and the medical impact that results from that. And about almost half of the families that we work with and continue to either do a child protective investigation or serve have substance use disorder as a risk factor. After child protective intake takes a report, if it meets the criteria for a child protective investigation, it gets sent to our district offices, and our agency is authorized through Title 22 to act to protect abused and neglected children that are in circumstances that have been abused or neglected, or that are in circumstances that present a substantial risk of abuse and neglect, to prevent further abuse and neglect, to enhance the welfare or the well-being of these children, and to preserve family life whenever possible. Staff have policy and procedures that they need to follow so that we can be sure that all of the allegations of child abuse and neglect are assessed. And some of the ways we do that are through engaging with families, contacting the referent and others who may have information about the circumstances for the children and the parents, conducting forensic interviews with critical case members, and then talking to medical professionals, law enforcement, and others who may have critical information that help guide our decision making. The last primary function that we have is related to permanency. And this is the process by which we support families where there's been a finding of abuse or neglect to resolve the safety concerns that we've identified. And if removal is necessary, to help those children exit DHHS custody, the reunification, adoption, or permanency guardianship. And we do that through a variety of different strategies. We develop a rehabilitation and reunification plan. Christine talked a little bit about the family plan. So when children are able to remain in the home with their parents and caregivers, then we develop that family plan. We meet with the family at least monthly. So we're meeting with the parents, the youth, and for children in care, their resource parents. We convene family team meetings. We coordinate services and monitor those services and remove barriers for families. We establish family visitation, and so we set that up so that parents and children continue to have contact. And and whenever possible, we want parents to be able to participate in doctor's appointments for kids, to attend their kids' baseball games and their school activities. And so we really try to provide optimal opportunities for contact between parents and children when the children can't remain in the home. And then we have a coordination responsibility in working with the courts, AAGs, parents' attorneys, guardian ad litem and CASAs, and others to prepare for court and have that court that provides the oversight and the final decision-making in our casework practice decisions. We also, this would be a place where, the recovery process that parent is part of would be included in that rehabilitation and reunification plan. And so that would be something that, we educate our staff about so that they can understand that recovery process, support that recovery process, and include that work as part of that plan. Next. In 2019, OCFS as a whole, but in particular, I'm going to talk about the child welfare visioning and strategic planning. So we engaged with stakeholders, KC Family Programs, and our own staff in order to look at the recommendations for system improvement, establish our guiding principles, our strategies, and the outcomes that we wanted to achieve. And so our strategies are bucketed in the areas of safety, so improving our analysis of safety for children, permanency, so making sure that children remain in our system as long as they need to, but not longer, and that we're helping them to exit to safe permanency outcomes. Well-being, so that we're engaging the family and we're looking at the mental and behavioral health needs of children. We're looking at the medical needs of children. We're ensuring that they are getting the educational supports they need, that they're connected to peers, and that they're connected to their culture and race. And then the last area is staff training and support. And so, we've been reviewing our policy and training processes, figuring out and implementing strategies to support our staff as they work with families, and looking at the workload and the caseload that staff have so that they have adequate time to work with families in the ways that we need them to do that. So this breaks down some of those child welfare initiatives a little bit more. And so with permanency, timely permanency, we have staff that have reviewed children, the cases for children who have entered care and exited care. We have created a permanency review process that looks at children who are in our system and where are they at in achieving permanency. You know, we look at what are the barriers for families and having their children reunify. How do we help address those barriers? If a child can't reunify, then are they on the path to adoption, and what will help them to achieve that outcome? We, policy and training I talked about, we are in partnership with Muskie to review our policies. The other thing that we do is we look at the policy that's being reviewed. So, you know, for example, we have a policy related to, you know, the commercial sex trafficking of children, and we would look at partners that work with sexual assault and bring them to the table to help us develop those policies based on their expertise. And then we develop trainings. We've developed trainings for our staff that are new to our system. We've developed trainings for our resource parents, and we also develop trainings related to policies and implementation of those policies. We focused a lot on onboarding, training, and retaining staff. Christine talked about Family First. Our alternative response program has been another area of focus. So improving the quality of those services in partnership with our community agencies and looking at how those services are meeting the needs of families. And then we've been developing a new information system. So up here, you'll see it referred to as CWIS. We call it Katahdin. Just some point in time facts. So as of 7/9, so as of the end of last week, we had 2,184 children in state custody. We had 1,744 foster homes, and that can be kinship, foster, and adoptive homes. And several of those homes are able to take more than one child. We are always looking for resources because as children adopt, as families adopt and move on, we are in need of new resources for kids. We had 3,998 children receiving child care subsidy. We had 17,758 children that had been authorized behavioral health services as of April 30th, 2021. And we had 354 children that achieved permanency between January 1st and May 31st, 2021. So one of the things I just wanted to highlight, because I think it's been, and we've heard throughout the day about the impact of COVID on the families that we all collectively work to support. And OCFS was part of that puzzle. And across our office, you know, looked at how do we best support families, children related to child welfare services, childcare, behavioral health, all of those areas that we know that families were struggling with. So this slide just outlines some of the ways, the guiding principles that we use. So we wanted to make sure data was driving our decision making. We ensured the health and safety, the health and well-being of our staff, as well as the individuals that we were serving. We had close collaboration with public and private partners. And so our, you know, providers, as well as, you know, we relied a lot on the CDC at the federal and state level to help us understand what was happening in our state and how to best, you know, make adaptations to our services. And then our goal was to protect the most vulnerable. And some of the ways that we did this within child welfare services was that we briefly replaced in-person parent-child visits with virtual visits, understanding that was a really difficult decision that we needed to make given the impact of the pandemic, but also understanding how virtual visits is not the same as a parent and child being able to be together and to have that in-person contact. We established guidelines to ensure the health and safety when we were doing in-person visitation. And so we worked with our visitation providers, our own staff, and others to establish what those guidelines would be. And then we limited our staff's in-person field contact originally in the counties that were deemed to have community transmission. And once it started to spread statewide, we really stepped back from that and did it based on the severity and the necessity of what was being reported. Ongoing, we partnered with the court in order to continue to move children through our system to permanency, which could have been reunification, adoption, or permanency guardianship. We ensured that children in custody were receiving their well child checkups and their vaccinations, and that work continues today for any children who may have missed some of those appointments. As we know, some appointments transition to telehealth appointments, that we're making sure that they're getting those appointments caught up. We transitioned training for staff and resource parents to a virtual format. We reported weekly COVID trend reporting for the Office of Child and Family Services. So that was broader than just child welfare, but there's a lot of child welfare measures in there. So from reporting to the number of kids in care to the number of children that were exiting custody. We had 85% of our staff dispatching from home. We obtained and distributed personal protective equipment for children in care, parents, resource parents, and our staff. And then we looked at opportunities to learn and improve practice. So some of the things that we implemented at the beginning, we made changes to as we've moved along in this pandemic in order to be responsive to the changing conditions and to the needs of families and children. And more recently, we provided guidance and encouraged people to get vaccinations, particularly for children in care. And I think we were successful in many ways as a state. I think the Office of Child and Family Services and the child welfare system was able to mirror some of that success that we have experienced. So we had less than 3% of our youth in care test positive for COVID-19. We had very few resource parents that reported testing positive, and we had a small number of staff who tested positive. None of the staff exposures were connected to work activities. And our system-wide efforts continue. They started pre-pandemic. We continued them during the pandemic, and we will continue them post-pandemic. We are a large piece of the social safety net for children and families, but recognize that our work is not done in a vacuum. It's not done in a silo. We really rely on our community partners to ensure the safety of children in the state of Maine, and that families have the supports they need when they're in crisis, or they need to be connected to recovery supports or other services. Other factors such as substance use, domestic violence, mental health, and poverty impact child safety. The department as a whole continues to make improvements in the system of care to positively impact child safety and well-being. And some of the ways that we're doing that is through partnership with other state agencies and community stakeholders to ensure that children born exposed to substances and their families have services and supports. We continue to tackle the opioid crisis and focus on addressing substance use disorder in youth. And we partner with domestic violence and sexual assault advocates to conduct a system-wide needs assessment to inform future funding and policy decisions. I think with the pandemic, we've seen those ripples sort of across the board, and families really in need of increased supports. And so as part of that puzzle and as part of the state community, we are partnering with others to meet those needs. Thank you.
Good afternoon. Thank you all for being here today. I especially want to thank all those here who are able to share their stories of recovery. It takes great courage to share your journey, and I thank you. My name is Dr. Adrienne Carmack, and I'm the Medical Director of the Office of Child and Family Services. I've been in this position since March of 2020, and as Bobby just discussed, there was much work to be done at OCFS to keep our children and our families, as well as our staff, safe and healthy during this last year. and that work continues. Before I came to OCFS, for the last 16 years, I've worked as a general pediatrician in the Bangor area, and I spent much time caring for children in foster care, as well as substance-exposed infants. I've seen how the life and health of a child can be affected by family members with substance use disorder, and I know the importance of treatment, support, and recovery. At our practice in Bangor, we worked very closely with many parents in recovery during that time, and I saw the value of family-centered collaboration. That approach can help care for infants and their families and for children in foster care. So next slide, Christine. So since I've been at OCFS, I've been involved in several initiatives to ensure that children who become involved with the child welfare system are receiving the medical care that is recommended. There are recommendations by the American Academy of Pediatrics and the Child Welfare League of America on the medical care that children should receive upon entering foster care, and soon after entry, a comprehensive evaluation should occur. And then children should have ongoing medical care while they are in state custody. We've had these initiatives ongoing, and we hope to improve and strengthen the system to be sure that children are receiving this recommended care. This involves the whole community. It involves public health providers, dental providers, medical providers, and mental health services throughout the community and our school systems. It takes the community to ensure that children are connected to these services that they need, and that there is communication amongst all the professionals involved in a child's life. This timeline shows that continuum of health services that a child should receive. And it's an example of one of the areas where we are working at OCFS to ensure that children receive these appointments and mental health services when they first come into care and during their time in care. As I said, this takes coordination, communication, and oversight. If you could go to the next slide. Within the Office of Child and Family Services, we have a program manager specifically working on child well-being to ensure that youth in care are getting the recommended services. We've been working on some of the policies that directly affect children's well-being, such as our immunization policy, policies around the psychotropic medication that some children may need while in foster care. They may come into foster care on medication, they may require medication. So it's important that children get the right medication and that it is prescribed by a knowledgeable provider. We're also working on the policy around substance-exposed infants. It's really important that the care of a youth in foster care is a coordination and a collaboration with community resources so that children get the mental health services they need as well, especially youth that are affected by the substance use disorder of family members. And so it's important that we collaborate with resources available through our children's behavioral health system and through our psychiatric providers if that is needed as well. So another program that we have that I'm excited to tell you about is the Plan of Safe Care. With the, if you were able to watch the program earlier today on Maine Mom, there was reference to the Plan of Safe Care. This is a program that we've been working on at OCFS to better serve infants and families that are affected by substance use disorder. Under federal regulation of the CAPTA regulation, which is Child Abuse Prevention Treatment Act, it states that the child welfare agency within each state needs to ensure that each infant that is born substance exposed, that there is a notification to the child welfare agency, and also that a plan of safe care is created. A plan of safe care is intended to be a public health centered approach to support families and offer an opportunity to work with caregivers of a newborn infant, to identify needed services, and then to provide connection and engagement to services in the community. In Maine, when an infant is born substance exposed, a notification must be made to the department, and then a plan of safe care is mandated to be created. We've been working over the last year and a half within the department and in partnership with the CDC, with the team creating, working with the Mom Grant, the medical community, are birthing hospitals, public health nursing, Maine families, and other providers of care of newborns in Maine to roll out our Plan of Safe Care initiative. So if you could go to the next slide. So a Plan of Safe Care is an actual document. And here we see it's a two-sided, one-page document. And since January, our Plan of Safe Care nurse, Ashley Olin, has been working to gather the information on our infants that are born substance exposed and the Plan of Safe Care that has been created for them. So we have been working to ensure that each infant has this plan. As you can't actually see the plan, but on it, on the front, we list demographic information about the parent and the infant and strengths of the family. And on the back are listed a variety of resources and needs that a family may have. And so providers can use this as a toolkit in order to engage a family with resources that they may need. We have things listed there such as connecting to WIC, connecting to breastfeeding support, medication-assisted treatment if that is needed, recovery services for the parent, child development services, or child care services needed for the infant. The Plan of Safe Care is not intended to be a punitive tool. It is intended to be a non-judgmental, non-stigmatizing way to help connect families to the resources in their community that can help ensure the safety of infants and the well-being of our families. For more information about the Plan of Safe Care, please contact me. We have a website, we have trainings, and there's information that myself or Ashley, our Plan of Safe Care nurse, can connect you with. My work also involves supporting the team at Children's Developmental and Behavioral Health, and Alyssa Wynn will now give you an update on those services.
Thank you, Dr. Carmack. Everyone, my name is Alyssa Wynn. I'm the Associate Director at the Office of Child and Family Services, like Bobby. However, I oversee all of our other programmatic areas within the office that is not child welfare. So there are two other large programmatic areas that we have within the Office of Child and Family Services. That's our early care and education programs and our children's behavioral health programs. Most relevant to the topic area today are the children's behavioral health services. So I'm going to try and take about 10 minutes to give you a very large overview of what we do in children's behavioral health, and I'm sure that I will not do it justice. It probably needs a longer time period by itself, but here I go. So up on the screen right now, you see the children's behavioral health vision statement. I'm going to start really big picture. So in 2018, we had an assessment done of our entire children's behavioral health service array. So that includes community-based services and that also for children with mental health, behavioral health, and including substance use disorder and opioid use disorder needs. As a result of that assessment, there were a number of recommendations for changes to the system that would better serve children and families. So we reviewed those recommendations with a large group of stakeholders, probably many of you that are listening today, as well as our internal staff. That group prioritized the recommendations to the top 13 that you see in the light blue in the middle there. We have separated them out into short and long-term goals. One of the 13 strategies, I'm going to talk about a few of them today that I think are relevant to you all, but one of them was to hire a full-time on-site medical director to support the state staff in overseeing the community-based services. And you just heard from our lovely Dr. Carmack earlier. So that's one of the strategies that we were able to complete and has made an incredible difference in what we've been able to do, infusing the medical perspective and the medical community into our behavioral health services. Next slide. So here you see what we like to call as the ideal children's behavioral health service system array. So what you see here is not actually what we have in Maine, but it's what we aim to have in Maine. There are a number of services that are missing from our Maine service array that you will see here. And then there are also some services that are not equitable across the state. Not every population, not every area of the state has access to all of the services that they need. And then there's also the question of, are the quality and or the evidence or the treatment modality, is that available to the children that need them? So I'm going to talk a little bit, I'm going to use this pyramid and refer back to it a number of times. However, as you can see, we want to keep children at the lowest level of the pyramid. That's where the cost is least, and it prevents them from having to escalate into higher levels of service. If this was more didactic, I would ask you to consider what would happen if a child needed a service at near the bottom of the pyramid and it wasn't there, or if they needed a service in the middle of the pyramid and it wasn't there. What I will say, and what I think that you would say, is that they tend to go up the pyramid more quickly if the service is not needed at the level originally that they could have accessed it. So what we're seeing in our system right now is that children are accessing services at the top of the pyramid and sort of having to wait in a level of service that may not be the right level for them. And so we're hearing that a lot from hospitals, emergency departments, residential facilities. And so our 13 strategies actually really address multiple levels of this pyramid, because it is a long-term solution that will take us sort of rebuilding and enhancing the quality at all levels here. Next slide, please. So one of our 13 strategies is to enhance our children's crisis service array. That was identified by the stakeholders as needing some work and some enhancements so that children have de-escalate from crisis as quickly as possible and then stay out of crisis long-term. So last year we implemented a pilot in Aroostook County, and where we were able to try out and see if children got supportive services, for a period of time after their crisis that included de-escalation, parent training, etc. Would they be able to discharge from hospitals sooner? Would they be able to stay out of residential care? Could it be preventative? So we did a pilot and we saw some really good outcomes preliminarily after 1 year of the pilot, meaning that children were able to stabilize and stay in their homes and communities more often than escalating to that higher level of care in their pyramid, in that pyramid I showed you. So with those preliminary results, we were able to use some of the COVID funding coming into the state to expand the pilot for an additional year and also make it go statewide. So now by June of 2022, we're going to have had it ongoing statewide for a whole year and for 2 years in Aroostook County, and be able to see if this is making a difference for children and families, and then assess the results and hopefully be able to either implement it or course correct as a result. So we're really happy with that, with being able to do this. I'm going to skip the next slide and go right to PRTF, Christine. One of our other strategies that was identified by the group was to establish a psychiatric residential treatment facility in Maine. This is a missing level of care. We don't have this level of care. It's below inpatient psychiatric hospitalization, but above children's residential. And so it's similar to inpatient, but can be longer. And it also has the ability to provide a bit longer term treatment for children. Without this level of care, we're seeing children, again, escalating higher up than they could have been treated at a lower level. So one of our strategies is to establish a PRTF in Maine. And what I will say, and I'm going to talk about later, is that every level of the pyramid that I showed, we want providers to be armed with the right tools and resources to serve the children that are coming to them. And that includes a co-occurring capable workforce. We want to infuse clinicians and practitioners across the state in every level of service with the tools that they need to serve youth and families that have co-occurring conditions. And so that's one piece that I want to make sure to touch on. I have 1 minute, I see. So let's go to that. Let's go to the SUD at the end. Christine, skip. All right, back. One more, back. Sorry. Yes, thank you. So what I want to say about this is that in 2018, Maine ranks 9th of all the 50 states in terms of the number of children that are affected by the opioid use disorder crisis. So that affected is defined as children who have had immediate family member die of an overdose, children who are living with a parent with addiction, children who have been placed into state custody because their parents have an addiction that has impacted their ability to safely parent, and or children who have an OUD themselves. So Maine is 9th out of the 50 states. I don't have any more time, but I want to tell you about the youth SUD work that we're doing in our office. We have a youth SUD specialist that has been hired. We have her for 1 year. That's Madeline Shiley. And we have her because of the generous contribution of the John T. Gorman Foundation. They were able to give us her to really scope the problem of youth substance use disorder and opioid use disorder in Maine, and then create a strategic plan about how we're going to address the gaps for that population. We are engaging stakeholders and staff. We're doing national research. We're working in collaboration with Gordon and the Opioid Council. So again, I would love to answer any questions or share more information at another time, but I appreciate the time here today. And with that, I want to thank everyone for having us.
And yes, we did run out of time for questions, but any one of us could be emailed, just our first name dot last name at maine.gov, and you could email us with any questions. We apologize for not having time for more questions. So.
My story really starts with this. Therefore, if any man be in Christ, he's a new creation. Therefore, old things are passed away. Behold, all things become new. And I say this because that was my journey in life. I was born with 2 club feet, addicted to heroin, and addicted to cocaine. The doctor told my mother that I never had a chance to even make it. People like me didn't make it in society. I grew up in Maine, from Illinois, but growing up, it wasn't easy for me. I lived in an all-white neighborhood, Irish Canadian. My family was white. I'm black. It was a little different for me. I grew up with racism. I grew up with hatred towards cops because of racism going through them. So my life and my identity was pretty much stricken for me. It was hate, anger. The way I was approached was different. And that's what I was taught my whole life, was hate and pain. I was molested as a child. I had to live with my molesters. When I finally came clean about my molestation, I was sent to another facility in JBI where I was molested again. So the system let me down. It was just more pain, more anger. Fast forward, I started getting into selling drugs deeper, finding my best friend dead. I started using crack cocaine, turned into coke, turned into daily use, a lot of coke, a lot of crack real fast. That was pretty much my life in a nutshell. It was drugs, selling drugs, all the way up to 33 years old. I met heroin for the first time, became my best friend. Started off sniffing. Not much longer then, I was shooting needles in my arms. And not longer after that, I died. And not longer after I died, I got arrested for trafficking. I probably did dope for almost a year, but in that year, I lost 15 friends. After getting out of prison after a couple of years, I fell flat back on my face, back into drugs, back right where I left off. All the things that, I promised myself I wouldn't do, I did. Ended up back in jail again within 3 months. And that is where I found my pathway. This group came to the jail, was giving Bible studies, and I remember reading the Bible before it even came, and I kept on seeing it rise, it rise, it rise. And I was like, whatever. And I go to the Bible study, and these guys identify themselves as a rise. So I started to listen. They gave me the Bible. I never heard the Bible taught like that. I heard preaching, but I never heard the actual story of the Bibles, the history, who these people were, and I was fascinated by that. When I got out, I didn't have nobody. I didn't have a reconnected community. I had my church, and but I wanted to help the people on the streets, different from what was going on. I wanted to meet people where they were. So when I found this place, actually it found me. There was a girl I helped to actually get into the church and get clean, and she introduced me to this place. And when I got here, I didn't know nothing about recovery. I knew Jesus, right? So blah, that's all I did. Threw up Jesus everywhere. And I guess it was kind of obnoxious, but I learned how to feel myself around, right? And I also came in with a lot of biases, right? So I identify myself not as in recovery. I identify myself as a student of recovery. And I say that because what I mean by that is I will remain teachable in my recovery walk. And in my walk, there's these tools that I retain. And in those tools that I get, they're gifts. And those gifts are made to be given, right? So I give those free gifts, whether it's MAT or one pathway or another pathway. I learn all these pathways, right? And I may not believe in every pathway, but that's okay. Somebody else does. And those tools that I get, I can give to other people. Since I've been in this recovery world, I'm now a recovery coach. I'm a trainer of recovery coaches, 3rd year in college, psychology, community studies. I'm learning about bonding and bridging community studies. That, all these are things that we do in our community centers. We bond and bridge cultures. Same thing in the church. We're bonding and bridging cultures. What normally wouldn't come together, we find a common denominator, right? Pretty much that's my story, man. Love. Love is my story. I found a community, a recovery community that decided to love me instead of treat me like a convict or an addict, throw me into a system, into bars and jails. They decided to say, hey man, that dude's a human. And I'm gonna love that person and my community to love me back to life. And now that's what I try to do, man. I try to love everybody else back to life. That's what I was taught. When I was taught hate, that's what I gave everybody, hate. When I was taught pain, that's what I brought to everybody, was pain. But when I was taught love, man, that's what I did. We need to stop hating each other and we need to start loving each other. We want the world to change? Love, man. Love.
Hi, everyone. My name is Keena Thakkar. I'm an infectious disease and addiction medicine physician, and I'm excited to be joined by my co-presenters, Dr. Michael Kohut, Dr. Rebecca Hutchinson, and Chastity Toole. And we're really honored to be sharing our research findings and experiences here today. The title of our session is Access to Harm Reduction and Treatment Among People Who Use Drugs in Maine During the COVID-19 Pandemic. We have nothing to disclose other than the funders listed here. And here are the learning objectives. The first objective is to recognize the relationship between substance use and COVID-19. The second objective is to identify facilitators and barriers to accessing harm reduction and treatment services during the pandemic. The third objective is to understand how trust impacts accessing harm reduction services during COVID-19. And the fourth objective is to give real-world examples of syringe service program or SSP adaptations during the pandemic. So here's an outline of the talk, which is essentially the learning objectives relisted. And I'll be starting with a little bit of background on substance use and COVID-19. So this study was published last year and involves about 73 million electronic health records. This was a case control study. And the researchers found that people with recent diagnosis of substance use disorder within the past year were at increased risk of developing COVID-19. And when they looked at different types of substance use, what they found was that people with opioid use disorder in particular were at higher risk for COVID-19, followed by people with tobacco use disorder. So we know that there's definitely a relationship between substance use and COVID-19. In terms of infectious complications, many of us in the infectious disease world were very concerned about and have been very concerned about people getting infections such as HIV, hepatitis, and other serious infections in the setting of injection drug use in the pandemic. And the research we have so far is from very early on in the pandemic. For example, in Chicago, they actually found that acute HIV cases increased from 6.8 to 14.4 per year. And in Boston, when they looked at hepatitis C, they actually found that new diagnoses were reduced by 60%. However, when they looked at testing, they also found that testing decreased by 50%. And anecdotally, that fits what we're seeing here in Maine. We're very early on, people were avoiding hospitals and avoiding, getting some of the care they needed. So I think that it'll be interesting to see some of the results from later on in the pandemic, because anecdotally, we are seeing a lot of infections here in Maine related to drug use. In terms of overdoses, these data are national data, and the bar graphs in red are overdoses pre-stay-at-home orders, and the bar graphs in yellow are number of overdoses post-stay-at-home orders from January 1st, 2020 to May 2020. And as you can see, the number of overdoses increased by 18% nationally. And now this is overdoses that were reported. So I think these numbers are actually a lot higher. So next we'll be discussing facilitators and barriers to accessing harm reduction services in Maine, and I'll be presenting some of our study findings here. Just to provide a little bit of context for our work, I wanted to share a case which is loosely based on someone I saw in the hospital recently, who's a 32-year-old woman hospitalized with infective endocarditis, a serious heart infection, in the setting of injection drug use. And she's not interested in substance use disorder treatment or stopping her drug use. So the question is, what are some helpful resources for this patient, especially during COVID-19, and what challenges may she face in accessing resources? So feel free to put some of your thoughts and answers in the chat or write them down as we move through the talk. So before we talk about accessing harm reduction services, I think it's important to review what harm reduction really is. And this definition is from the National Harm Reduction Coalition, which is harm reduction is a set of practical strategies aimed at reducing negative consequences associated with drug use. And I think it's really important to recognize that harm reduction is really a movement for social justice. It was started by people who use drugs, for people who use drugs, and things like syringe service programs, yes, they encompass needle exchanges, but they also encompass things like naloxone distribution, peer support, community mobilization, advocating for things like safe consumption sites and policy reform, housing first advocacy, and all of these things really encompass harm reduction. So in terms of barriers to accessing harm reduction, we know that before COVID, people faced many barriers. And actually, we have some research that's going to be published in one of the harm reduction journals, hopefully this month, where we found that people in Maine specifically who lived more than 10 miles from a syringe service program were less likely to use one. And so we know that travel and transportation issues are definitely barriers in rural states like Maine. Other research has also shown that fears of law enforcement, concerns about confidentiality, stigma, distrust of providers, which Dr. Kohut will talk about in his session, are also barriers to harm reduction services. And really, in order to make successful harm reduction, we really need to help minimize barriers and make these services as low barrier as possible. And here are some data from a previous study, again, which should hopefully be published soon, on 101 patients we surveyed in the hospital with infections related to injection drug use. And the bar graphs in orange here represent practices that people did rarely or never. And so as you can see from the box on the right, very few people use a new needle or syringe every time they were injecting. Very few people use new cookers or filters every time they were injecting. And this is because of many of the barriers that they faced. In this particular study, distance was one of the main barriers. And what was going on in Maine at the start of COVID-19? Well, unfortunately, drug overdose deaths in Maine jumped to 127 deaths in the first quarter of 2020. There was a temporary closure of the Portland Syringe Service Program in the first 2 weeks of the pandemic. Fortunately, Governor Mills made an executive order with several policy changes to help improve harm reduction services. So there was expansion of mobile outreach. She allowed the mail delivery of equipment, and also elimination of the one-for-one needle exchange. And for those of you who may not be familiar with the one-for-one, it's sort of like it sounds in that someone brings in a used needle or syringe, it gets an unused one in return. And so while these policy changes were widely implemented in some areas, some particular urban areas like Portland actually did not implement them. So parts of Portland were actually still implementing the one-for-one needle exchange. So we'll talk about some of the implications of these policy changes in the next few slides. And the map on the right is the counties in orange are the counties that have been deemed high risk for HIV hepatitis outbreaks in Maine by the CDC. And the green stars indicate the syringe service programs at the start of the pandemic. And Chastity will talk about how some of the SSPs have expanded since then. So as I mentioned, the main goal of the studies was to identify facilitators and barriers to accessing harm reduction and other treatment services. And so in this study, we did 36 semi-structured interviews with different stakeholders, which included providers, community partners, and people who were using drugs. And the interviews really focused on changes related to COVID-19 and the pandemic's impact on access and on health. And for this particular study, we used something called the framework method, which was previously described by researchers. And it helped us categorize different facilitators and barriers into 6 different dimensions of access, which you can see listed there. And I'll talk about a bit on the next slide. So this is a table summarizing our findings. The first column are different dimensions of access. So accessibility, essentially, location, availability, supply and demand, acceptability, which is essentially consumer perception of the service, adequacy, things like organization, service hours, affordability, and awareness, which really speaks to communication and information about the service. And the second column, you can see the different facilitators to harm reduction services that we found. The third column are barriers to harm reduction services. And for the purpose of this talk, I'll be focusing mostly on the facilitators that are highlighted there in blue: mobile outreach, mail delivery of equipment, and elimination of the one-for-one needle exchange. So here's a slide summarizing some of the key facilitators and barriers. So as you can see in the first box, again, mobile delivery of equipment was really key. And many of the people we interviewed found that the mobile outreach delivery was very helpful. They didn't have a problem in getting clean equipment when they needed it, especially those people in rural areas. Eliminating the one-for-one needle exchange was also very helpful for the same reason, in that people had the clean equipment when they needed it. And again, mail delivery was important because there were some people who just didn't want to risk going out in public. Some people prefer not to go to the pharmacies, or they just didn't have access to transportation. So mail delivery was really very important in getting people things like naloxone and equipment when they needed it. In terms of barriers, some of the barriers we identified were stigma. Some people didn't feel comfortable going to a syringe service program that was out in the open, or to the pharmacy where they might potentially have a stigmatizing encounter. One participant, in terms of the one-for-one exchange, as I mentioned, Portland, for example, certain parts of Portland were still practicing the one-for-one. And so, one participant, for example, said that, she felt that policy directly led to her having a bone infection because she had to reuse her needle. She didn't have access to a clean one, and she was really concerned about, her risk for HIV, hepatitis, and other infections. So, that policy was very restrictive. Also, although I think the syringe service programs did an amazing job given the difficult circumstances, there was still limited service capacity. I mean, they can't operate 24/7 sometimes. And as I mentioned before, distance was also a known barrier to harm reduction services. Over the next few slides, I just wanted to share some what I thought were interesting quotes for some of the study participants that really highlight some of the key facilitators to accessing harm reduction services. So one is the suspension of the one-for-one needle exchange policy. And this quote is from a community partner who said, going from 100 needles or so down to 10 puts an individual in a position where they have to make some choices. And if they don't have ready access to a pharmacy or don't have the money to purchase syringes, then they're in a position of making a risky choice. Do they reuse? Do they borrow from someone else? It's just a situation that doesn't need to happen. The second quote, the second slide is from, about mail delivery of equipment. And the first quote here is from from a community partner. And this community partner was saying, I just want to stress again how essential the mail distribution of supplies has been. We've been mailing a lot. The fact that people had to drive 3 hours each way to access the closest exchange was always an issue, pre-COVID, post-COVID, whatever. That's just baseline and barrier. And this participant described this mail delivery of equipment as transformative. The second quote here is from someone who was using drugs, describing the organization that mailed equipment. And they said they only deal through text message, but they mail you a box of stuff every time I go. The pharmacists are just trying to say, I don't have the needles and blah, blah, blah. It's just like, you can't be all out. And so, this person was talking about also how when they went to the pharmacy, they felt it was sort of a stigmatizing encounter, and mail delivery of equipment really made things a lot easier for people. And finally, just touching on mobile outreach, this quote is from a community partner. who said folks, especially in rural counties, have been doing mobile naloxone outreach, going to different outdoor places, setting up a table, kind of having a social distance space. And now it seems like there's been this real shift that's been really effective, and people have been accessing services that way. I think partly because there's more anonymity. You can kind of show up, you're in and you're out. We also identified many other themes in our study. For the purposes of this talk, we won't have time to go through all of them, but I just wanted to share them. One was basic needs, which is really, participants talked about the importance of housing, food security, all of these things. And, thinking about COVID-19 safety, one participant described as a luxury, really, because they were so focused on these basic needs. Resilience was another theme, which Chastity will talk about. Community partners really continued service delivery despite a lot of challenges, particularly early on in the pandemic. And the third theme was trust, which Dr. Kohut would touch upon. So getting back to our case, our young woman with endocarditis, and thinking about helpful resources, what we discussed while she was in the hospital was the option of mobile outreach, SSPs. She actually wasn't aware of mail delivery of equipment, so we talked about how she could access that. And we also talked about the elimination of the one-for-one needle exchange and how she could maybe get equipment through peer exchange. And then we talked about some of the challenges, which I mentioned earlier. So in terms of study implications, basic needs really should remain a priority: housing, food security, addressing stigma, all of these things. We identified several facilitators and barriers, as I mentioned. And although we are still, unfortunately, very much in the midst of a pandemic, thinking, beyond COVID-19, our study, I think, really shows that we need to maintain some of these facilitators, like eliminating the one-for-one needle exchange. And we really need to focus on expanding harm reduction access, supporting mail delivery of equipment and mobile outreach. So next, I will turn it over to Dr. Kohut.
Thank you, Dr. Thacker. Hello, everyone. My name is Mike Kohut, and I will be talking about the impact of trust and distrust on harm reduction and treatment services access during COVID-19. So this portion of the talk is based on the same interviews that Dr. Thacker has already described, but was based on a secondary analysis. So in other words, after she had we had gone through and identified these major facilitators and barriers and some of these other themes that were mentioned, we went back through to do a deeper dive on this particular theme. And we found that issues related to trust and distrust in particular were very highly salient. In fact, 3 different analysts went through the transcripts and independently identified these as being major issues. And looking through how often they were brought up, around half of the interviewers actually brought up something related to trust or distrust and how important that can be. So as part of the process of kind of developing these themes, we looked at all the instances in which trust or distrust were brought up, and then really mapped out the specific kinds of impacts, and that's what I'll be discussing with you today. So the 2 themes that I'll be focusing on, first of all, will be broken engagement, and then secondly on alienation, and then at the end I'll try to bring these all together to kind of describe how this is all impacting access. So first of all, the issue of broken engagement, to kind of summarize this, service providers, as Dr. Thacker mentioned, of harm reduction services really try to reduce different kinds of barriers. And one way to do that is to build up trust with people in the community so that they feel comfortable coming to them for these needed services. The issue that was brought up, though, by a lot of the community partners and the providers that we talked to was that in order to build that kind of trust, you really need to not only interact with people who inject in a non-judgmental way, but you also need co-presence. And this is something that actually is not often discussed in the literature, but which became highly, highly salient under COVID. In this particular quote, when I'm meeting someone face to face, I can convey to them, I hope really genuinely, like, I see you, I respect you, and I'm going to take care of you. Now, one of the issues, and go ahead and advance, that came up during COVID is that there just were not as many opportunities for this kind of co-presence. So partners at the Portland Needle Exchange talked about how they had switched to pre-packed bags and had moved their table and outreach outside. Now, this is in contrast to previously where a person would come, they would meet inside and oftentimes be surrounded by different kind of posters with information about harm reduction and be able to have a conversation with a harm reduction provider in order to really think about and get more information about harm reduction. Peer recovery partners talked about how they were no longer allowed access into jails and shelters, which was formerly part of their outreach program to reach out to people who inject drugs, form those kinds of relationships that in certain circumstances might allow them to bring them into some sort of treatment or other kind of support. And then also the limited hours and reduced, or because many of the shelters had to reduce their hours. Some also reduced their mobile outreach units. And in that way, they weren't able to make those day-to-day kind of contacts and building up those relationships that they would have been doing before. So this less amount of co-presence also meant fewer opportunities to build trust. Go ahead and advance. And as a result of that, these kind of social distancing policies really made building new relationships more difficult. And some of the community partners would talk about the advantage of having already built those relationships with certain people and how that actually led service interruptions to have less of an impact. The place where it really did have the impact was in bringing people into harm reduction. One psychiatric consultant at MMC brought up the idea of missing these key moments. So it's difficult to engage patients often. She talked about what I really worry about is that we're missing these moments where the patients are ready to engage. And even the smallest hump or barrier can turn that patient away. And so this is something that happened more often during COVID because of these additional restrictions. Go ahead. Now, the second theme that I wanted to talk about was alienation. And this often came from the participants we had who injected drugs. And one thing that they talked about a lot was feeling a lot more stigmatized during COVID. They talked about that coming from the community, from different business owners, and from the city government. This participant here, who I've used the pseudonym Jen to refer to, talks about how things have been closed, the soup kitchen, that they're constantly being made to move. And she says, pretty soon we're going to be left with absolutely nowhere to go. Go ahead and advance. And in particular, the not only were there kind of these perceptions about feeling more stigmatized, but in many cases, COVID restrictions themselves were being understood as a kind of discrimination or stigma. And so people would talk about, for example, the inability to use public restrooms or efforts when going into a grocery store or pharmacy to use a restroom, that if they did not have a mask, they were told that they couldn't come in. And sometimes they saw these as being unfairly targeting these particular groups who inject drugs or who are homeless. So we have this quote from Danielle that says that if you go in to one of these places, they're going to see if there's any way that they can basically keep you from being able to come into their facility. And keep in mind that these kind of public restrooms can be a safe space for injecting, and without them, people are on the street injecting, which is a lot more stressful of a circumstance and can lead to more complications. Some of our community partners criticized in particular the classification of certain harm reduction services as being non-essential, which of course had major implications for whether they were able to be open and reach out to people. And then there was also noted that some of the poor communication about service changes exacerbated some of these issues. So even though the Portland Needle Exchange was only closed for a couple of weeks, many people thought that it had been closed indefinitely. And so they felt in some ways sort of abandoned by the city. Okay. And this sort of accumulation of stigmatizing experiences and understanding it through this sort of lens of stigma of COVID restrictions led many people to feel alienated from the system and distrustful of different kinds of authorities. And in some ways, and you can see that in this quote here from Danielle, I kind of feel like they're hoping that we kill each other or kill ourselves off. that they're really seeing the city and these other authorities as looking at COVID as an excuse for causing this community more harm or for getting rid of these people that they see as being undesirable. And it's possible that some of this distrust also became associated with or linked up with some skepticism that we also heard around COVID-19. In particular, I heard from a number of different participants a notion that in a way kind of turned what might be considered to be a weakness into a strength. So they would talk about how the fact that people who are homeless are living in less sanitary conditions or exposed to more diseases, that actually makes them stronger and much more able to survive if they did get COVID, and kind of contrasted that with other kinds of people that are more susceptible to this sort of thing. So all of that basically would lead to a circumstance in which people would be less likely to engage with medical services. And there does seem to be some evidence that the use of emergency services, example by PWID, decreased during COVID-19. So we can ask ourselves, why might this have happened? An easy kind of answer might be, well, they're concerned about COVID-19. But of course, in many of the interviews, it sounds like concern about COVID was fairly minor for some people. Now, that is not for everyone. There certainly is concern about COVID-19, but it wasn't a major concern for most of the people that we talked about. Could it be distrust of medical providers? And certainly we heard cases of people talking about being worried to go to the emergency room, not expected to be treated very fairly. But ultimately, though, I think that it's a little bit more complicated in that it is more of a fear of how the medical system would treat members of the stigmatized community in the context of COVID-19. So we did hear this story of someone who went to the emergency room suffering from a different issue related to his heart, but was immediately shuffled into a room with other people with COVID. And this is something that maybe happened because they were either being misunderstood as having COVID or for some other purpose. But as a result of that, this person left the hospital fearful and never received any kind of medical decision. And there are similar kind of fears around being quarantined, which one community partner described as being worse than being in jail for an injection drug user. So in order to kind of summarize all these findings, on the left here, we see this, what we heard around this broken engagement. So typically, people who inject drugs engage with services. They understand that service providers care about them because they're there, they're co-present. So they build this trust up and they continue to engage with those services. Under COVID, of course, that's broken. So that's no longer happening. And instead, what we get is this ramping up of distrust. So we have these additional experiences of stigma, in more distrust of authorities, and then disengagement from that system. So just to talk about some policy implications really quick here, I'm not going to be able to go through all of this, but it is important to consider the relative impacts of different kinds of policymaking. If they could be very well intended, but they could have very long-term consequences among communities who inject drugs and make future work more difficult than before. It's important to always be able to ensure that community partners and other providers are able to continue to engage with people who are injecting drugs. It's a way to be able to get them harm reduction services or treatment if that's what is desired. And we did find that overall harm reduction programs that were more flexible and were able to kind of meet people halfway and maintain those kinds of relationships were better able to engage with them. Thank you all. And I will now turn the slide over to Dr. Hutchinson.
Hi guys, thanks Dr. Kohat and Dr. Thacker. I'm Becca Hutchinson. I'm a palliative care doctor at Maine Med, and it's been a pleasure to work on this project with my colleagues. So I'm going to focus my part of this talk on the impact of telemedicine on substance use disorder treatment. And we feel like this is a really important part of the talk because although hopefully the pandemic is resolving, and we won't be in a situation quite like we were when everything had to shift to virtual. We do think that there are probably some lessons that can be learned from the pandemic and the use of telemedicine and applied to the care of rural patients moving forward. Next slide, please. So as Dr. Thakrar has described, and as you all probably know, opioid use disorder disproportionately impacts people living in rural environments. And there is just less access to specialty providers with expertise in addiction medicine. And this is especially limited in rural areas. Telemedicine is something that has frequently been cited as a possible way to solve this access issue, not just for addiction medicine, but for many other subspecialties. However, we don't really know how well telemedicine works for this population in this setting. The COVID pandemic, as we all know, resulted in a rapid uptake of the use of telemedicine for addiction medicine. And really, as I was trying to say earlier, provides us with a natural experiment to understand the pros and cons of telemedicine and to think about how we can optimally use it moving forward. Next slide. So you've heard about the methods that we used for this project. This particular analysis focused on the 22 participants that talked about the impact of telemedicine on the treatment of people who inject drugs. And we had 3 coders who coded the content for themes around telemedicine. And we really focused on the impact of telemedicine, both voice only as well as video supported, on the patient and provider experience and access to care. Next slide. So our data is based on 6 people who inject drugs, 7 community partners, and 9 providers. Next slide. And here are the overall themes that we identified. You can see we sort of separated them out into 3 big buckets: care acceptability, care accessibility, and care adequacy. And the green are things that improved those sort of buckets or made care acceptability better. And the red are things that made care acceptability potentially worse as a result of using telemedicine. So I'm going to go into more detail about each of these themes. We can go to the next slide. We're going to start focusing on the center of care accessibility. This is the parts of our findings that are probably the least surprising. So I'm not going to go into a great amount of detail talking about the pros and cons of care accessibility, and just sort of mention the big buckets of increased convenience, which, I think most of us realize telemedicine sort of offers that because you can have the encounter from your own home. There's an elimination of a transportation barrier, and also increased options for care. The only quote that I'm going to share for this green bucket of the improvement in care accessibility is a provider who said we could take out several of those steps, which would let people get jobs and pursue housing and other things that they're working on. So in other words, by making substance abuse treatment have less barriers to access, patients or people were able to take care of other things, other needs that they were having. In terms of the cons, people talked about how there was some difficulty with care coordination. So when people used to get their treatment at a site, they used to be able to have see multiple providers at the same time, and it was really easy to coordinate that care. Whereas in the current setting with telehealth, it was harder to be able to coordinate all of the different people together. And the final thing is technological barriers. And this is sort of the things that we know about, like broadband access and connectivity, but also just the fact that it required people to have cell phones, and some people didn't have cell phones. So one of the quotes was, a lot of different services became almost inaccessible if you don't have a cell phone. And the other aspect in terms of that we put into this technological barrier bucket was the need for a private space. And so some people, especially those experiencing homelessness, might not be able to find a private place with secure internet access. We'll go to the next slide. So now we're going to move into the big bucket of care acceptability and talk about a few of the pros. So the first pro that was kind of interesting that patients described was a decreased sense of shame. So the quote was, but it's a lot easier not to see somebody and tell them how crappy you're doing, look them in the eyes, and it's a lot less shameful, I guess. So that sort of distance that telemedicine provides, that often we think of as being negative, actually helped the patient to feel less shame. In addition, people talked about how there was a comfort added of being in their own home. So the quote is there on the screen. A lot of my women don't like this sort of scene before and after meetings if they feel like it's almost like they're getting asked out and stuff like that. And they said they like the privacy of their own home and not having that sort of social interaction. So that sort of comfort that comes from being in your own home, maybe having things be a little bit more predictable, can be a pro in terms of care acceptability. Go to the next slide. In terms of the cons about care acceptability, the first that we identified was a decreased structure. So this was really sort of people talking about how with virtual meetings, it was easier to be in a meeting and not engage. So for example, you can kind of be present, maybe have your screen off and not really paying a lot of attention to what's going on. Whereas when you're in person, it's harder to do that. Another thing that came up was decreased peer support. And this one, the quote is up there. So it's just talking about how, in the beginning, you might be feeling like you're crawling out of your skin, and being in a meeting where you're around other people that maybe are having the same or similar experience really adds a sense of kind of peer support, and that you don't feel totally alone and you're exposed to a positive message. So that was sort of a con in terms of having meetings being virtual. And then the final thing was decreased privacy. One participant mentioned knowing that their patients were in a domestic violence situation and hearing the man in the background and how that caused some discomfort for the other people in the group. Next slide. So now we're in the third bucket, which is care adequacy. On the pro side, providers especially talked about how it was nice to be able to understand better the patient's social or the participant's social context. So I got to see patients in their home environment, which was very educational for me. I got a better sense of their environment and how things were in their home, whether they had small things like their pets, how the house looked, and whether they had privacy. So just sort of better understanding the lives of the people that they're treating was considered a pro in terms of care adequacy. You can go to the next slide. In terms of the cons, there were two cons. One was missing important body language and physical exam signs. So the quote there is, if somebody is really disheveled, you can tell on video, but there's more subtle signs that are hard to see when you're in a virtual environment. And then decreased human connection is a really kind of interesting one that was brought up by several of our participants. And the quote for that was, and so I think not having that face-to-face to me has meant a lack of consistency and a lack of physical presence to build that baseline trust with each other, which then causes a lot of gaps in the services that people need. Go to the next slide. So in summary, what we found related to telehealth is that although it is imperfect, telehealth certainly has big advantages in each of the three buckets that we talked about. Most of our participants felt that video was much better than audio alone. And, people talked about the importance of personal connection and that maybe some of that can be formed virtually, but for other parts of that, for example, maybe early in recovery, the kind of human contact is really important. And then finally, there's just no one size fits all, right? So for some people, being virtual actually decreases shame and helps you be honest about what's going on. And for others, it might be a barrier to, as Dr. Kohut talked about, forming a trusting relationship with your provider. Next slide. So our recommendations are that telemedicine should be a part of care offered to people who inject drugs moving forward, that video should be strongly encouraged over audio alone, and that a hybrid approach that integrates telehealth into in-person encounters is probably better than virtual alone and maybe better than in-person alone. Policy efforts to improve access to care, which should include both broadband access across our state and also improving access to devices, are critical to prevent a growing digital divide. Next slide. Turn things over to Chastity.
Hi, everyone. Thank you. I am Chastity Toole with Maine Access Points. I'm going to give you some real life scenarios of working in harm reduction during the pandemic, but I'll start with just a little background on Maine Access Points for those that don't know. We started in late 2018, a very small organization that focused on overdose education and naloxone distribution in rural Maine. We prioritize our distribution of naloxone to people who use drugs and those close to them. You can go to the next slide. During COVID is when things really got interesting for us, because the same time that the world shut down is the same time we started all of our syringe service programming. And as everything around us was shutting down or reducing capacity, we had exponential growth. In April 2020, we started our mobile outreach program in York County. In May is when we started our mail program that serves the entire state. Washington County started with a mobile site in July in Calais, and then expanded to a physical space and mobile site in Machias in March of this year, and Aroostook County in April of this year. So when we talk rural Maine, we're really rural Maine. We were fortunate enough to meet with all of the other syringe service providers throughout the state and the Maine CDC and OBH and governor's office through the pandemic to discuss challenges, what's working, what's not, what do we need, and really make our program work. Ours is a little different than everyone else's. More that we're mobile. Most of us don't have a physical location. We're completely peer run and peer based. And all of our program directors are people already embedded in the communities doing that work. There's been some pros during COVID, obviously. Getting Executive Order 27 did a lot for us, not having to have a fixed site. I started in Calais with a fixed location that the town approved, the CDC approved, and nobody came. Being able to focus on doing deliveries and actually going to people in a place that feels safe for them or that they're comfortable with has done a lot. It's, helped with transportation barriers, but really established trust for people as well. Having the flexibility of time and location, and then with Executive Order 33, being able to do the work countywide, increased both geographic access, but also an element of trust and care when we can and do drive out of our way to meet people to get them what they need. Just last week, in a matter of 2 days, I traveled close to 800 miles to go out and meet people in just 2 days. And not only did they get what they need, but there was one instance, a participant who started in our mail program and then moved to my area a couple hours away. I got to go meet with them, and we sat for an hour and a half and talked, and they got referrals for school and housing. They introduced me to other people in their community, and now I'm being invited back by their town to do some trainings up there. So the relationship building has been unreal that I don't know we would have got without COVID. So it hasn't all been terrible. All of our programs are word of mouth. We have a social media presence, but not tons. We don't put out a lot of advertising stuff. So everything comes word of mouth. So people know who they can trust and who they can't. And we keep participants as partners. We listen to their specific needs and incorporate what they need. If one area prefers easy touch syringes over the BD syringes, we make sure that that program is stocked with easy touch. And we also do a lot of distribution of safe smoking and snorting supplies, where traditionally speaking, stimulant users are left out of harm reduction programs, as the focus is on the opioid epidemic. And it widened our reach to connect with people who aren't just IV drug users. While building relationships and building trust, and everyone knows overdose deaths went up in Maine this past year, but the amount of reports that we've gotten of peer reversals also went up a lot. And I don't think people would understand how much trust has to come from that to be able to report to someone, hey, just last week, I had to Narcan 3 people that I love. Thank you for getting me what I need. It's a blessing, and it's also kind of scary that someone had to go through that so often, but they thank us for it. There's also a lot of cons in this work, especially in rural areas where underfunded and the resources, we don't have them. We all have a large geographical area, and we have one staff person per area. So one for all of Aroostook County, one all of York, and me in Washington County. And so we, as much as we'd like to be able to do 24 hours a day, 7 days a week, it's not realistic. So we've accommodated where we can, and we make sure we get to people whenever they need. It doesn't have to be a traditional office 9 to 5 thing. We'll make it work. Another con has been the temporary nature of the rule changes. We still don't know what the permanent rules will be, and we're trying to be really transparent with participants about that. So it can be hard to navigate because, as we all know, the 1-for-1 is very harmful. New participants come all the time, and if they don't really know us, they're not going to tell us, I really need 20 syringes in a day to get through and be safe and have a new one each time. They always lowball. So like being able to build trust and know like, hey, you need 300, we're going to get you 300, and that's okay. And another con is there's still a lot of stigma in our communities about harm reduction programs, syringe service programs in general. There's been a lot of participants that have, come back and talked about being in the emergency room and how they were treated. One of our own team members had a simple cat scratch and had to go to the emergency room. And the very first question was, are you an IV drug user? And they said no, but they still were not treated with the care they should because it was assumed it was an injection problem. Rural Maine, we have many unique challenges compared to Portland. We're really geographically spread out. So we don't have a homeless shelter or encampments where we can go out and we can get 30 people what they need right there. To see 30 people, we're gonna travel a long time, spend a long time in a car. So we don't see the same number of people, but we still have a massive reach. You can go to the next slide. Since January 2020 and through the end of June, as an organization, which includes our syringe service program and our community distributors, we have people in all 16 counties that distribute. We've distributed 36,830 doses of naloxone. It doesn't all come from the syringe service program, but a large percentage of it is. We have 486 unique enrolled participants for a program that's not even a year and a half old. And we've distributed almost 750,000 syringes in the same timeline. Despite all of it, we've managed to build an effective program for rural Mainers, and we still have limitations and barriers, but we're thankful for all the work that's being done throughout the state and from all of our partners as everyone adapts to really meet people where they're at. If anyone would like more info on our programs or how to get connected to one of our syringe service programs or a referral to one in your area, it's all on our website. And if anyone needs naloxone, we will mail that to anybody in the state. And we've really simplified that by adding an online ordering form on the website as well. But call, text, and signal is preferred, and we will get anything you need to you. And that's it for me.
Okay, great. Thank you, Chastity, and thanks to Dr. Kohut and Dr. Hutchinson. So I'll just be kind of talking about some take-home points based on everybody's presentation. So, as I mentioned in my portion of the talk, we definitely identified some facilitators and barriers that can really inform some policies in our state moving forward. And as Dr. Kohut discussed, any policy changes should really be sensitive to impacts on trust building, as I think he discussed that trust is really important to accessing harm reduction services. And then as Dr. Hutchinson described, policy efforts to improve access to care are really critical to prevent a digital divide. And then as Chastity said, the programs like Maine Access Points really did adapt during COVID-19. But there's still challenges, like she mentioned, that they still face. And so we hope that today's presentation sheds some light on some of the lessons that we learned during the pandemic and how we could potentially move forward to really help increase access to services and people in our state. So I just wanted to acknowledge the study participants, our funders, and our study team. And we're happy to take questions if there are any in the chat, or feel free to contact any of us afterwards if you have any questions. Thanks again.